Committee Room 29, sound. Committee Room 29, sound. Committee Room 29. Committee Room 29, sound. 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 Committee Room 29. 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 Sound. Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound.
Public should welcome our work experience students. You're very welcome for however short or long you stay. This is where the real action happens in this committee. So it is. So anyway, the meeting's open to the public. Just to advise members, the meeting will be recorded online and broadcast throughout Parliament buildings. Just to advise everybody in the public gallery, more than welcome to use mobile devices, as long as they're in airplane mode and are muted. There's Wi-Fi there, you can connect to it, the passwords are there. It's not permitted to take photographs or record any of the meeting. So, just before we actually begin the meeting, I just think it's important that I acknowledge the racist attacks and intimidation that we've witnessed across the North in recent days. As Chair of the Health Committee, I definitely think it's important to reiterate that our health and social care service relies on a diverse workforce, many of whom are now feeling frightened, vulnerable as a result of what they have witnessed and what has happened in the last couple of days. I've heard directly from leaders within our health system just exactly how the last couple of days have impacted staff. Some are afraid to leave their home, some are afraid to travel to work, and as we heard on the radio today, some are actually being chased into their place of work. None of this is acceptable. No healthcare worker should have to fear for their safety simply because of their ethnicity or their background or the colour of their skin. So I want to place on record my solidarity with all those affected and reiterate that racism, hatred or intimidation have no place in our society.
You're here.
Okay, so moving on. Just apologies. With apologies from Linda Dillon. Anybody else? No. Okay, Chair's business. So just to let you know, members, the committee have received an SL1 from the Department in relation to hantavirus. So at a very high level, the proposed statutory rule seeks to add hantavirus to the list of notifiable diseases under the Public Health Act. The Department have advised that a second SL1 related to hantavirus may follow in the coming days. The Minister has written to the committee requesting that the SL1 is considered on an expedited timeframe and to the standard 4 weeks. It's proposed that the committee would both take oral evidence from the department and take a decision on the 2 SLs at next week's meeting. So this may mean that a decision is taken on SL1 before the call for views has concluded. However, any further responses received after this would be considered by the committee once the subsequent SR is laid. So are members content with that? Okay, thank you. Are members content, that the request for an expedient time frame and proposal to consider the SL at next meeting, so we are, and that we issue the call for views immediately on the SL1. Okay, so just a couple of things in terms of Chair's business. I just want to put on record my thanks to RCN. I was invited to the Royal College of Nurses Nurse of the Year Award last Thursday evening. Really good event showcasing all the excellent work that we as members of the Health Committee know that our nurses do, and I want to put on record my thanks to our nursing staff and congratulating all of those who were nominated and all the winners. In particular, I just want to pay tribute to Brona Scott, who won the Kathleen Robb Award for Outstanding Contribution to Nursing, and in particular Linda Hamilton, a nurse from the Belfast Trust, who won Nurse of the Year Award. So I just want to congratulate them for their achievements. Just also was invited to this morning the All Ireland Network on Social Prescribing Conference in Dundalk. So I just want to thank them for the invite this morning and to put on record just some of the kind of work that social prescribing does and the impact that it can have at a very low cost within our health service. So myself and Danny, committee staff and the permanent secretary, in our visit to London, we had an opportunity to engage with GP practices. We also had an opportunity to engage with social prescribers, and they were very enthusiastic about the work at a very low cost that they can have within our health service. So I just want to thank the network for my invite to that. So that's Chair's business. Okay, moving on, draft minutes of the meeting held on the 4th of June at page 6. Everybody content? Okay, matters arising? None. Okay, item number 5, which is SR 2026-103, the JAM and Similar Products Amendment Regulations, NI 2026. So papers, page 20 to 30 of our main pack. Purpose of the SR is to provide for updated compositional requirements for jelly and extra jelly. And who doesn't want extra jelly? Anyway, the SR is subject to negative resolution procedure. Committee considered and approved the proposal for this SR at its meeting on the 21st of May. So the Food Standards Agency has confirmed that there have been no changes to policy content since the SL1 was considered by the committee, and the Examiner of Statutory Rules has not yet reported on the SR, and the committee will consider the SR again if any issues are identified in the Examiner's report when published. But I'm going to ask members to formally agree that the Committee for Health has considered SR 2026-103, the JAM and Similar Products Amendment Regulations, NI 2026, and subject to the Examiner of Statutory Rules report, has no objection to the rule.
Chair?
Yes, Dan?
Just to say that this is as a result of the transposition of an EU directive in Northern Ireland and not in the rest of the United Kingdom. And on that basis, I would have to raise my objection to the rule. Okay, thank you.
I go with that.
Okay, do we need to vote? Can we have a vote then? Can we have those members, if you just raise your hand, those who are in favour of the SR? 1, 2, 3, 4. Those against? 1, 2, 3. Okay, so the rule is passed. SL1, Food and Feed, Miscellaneous Amendments, Revocations Regulation NI 2026. So this SL1 is in our papers, page 31. The Food Standards Agency is proposing to make a statutory rule. The purpose of the proposed rule is to amend existing delegated legislation regarding food and animal feed safety and standards to enhance consumer protections and clarity. It's the first occasion the committee has seen this SL1, and we're not going to make a decision about the policy merit at today's meeting. What we're going to do is note the SL1 information and papers will then be published on the Assembly website, and a call for views will be issued. We will then agree that the SL1 will be scheduled for consideration at our meeting on the 2nd of July. I'm going to ask if members want to be briefed by officials on the proposed rule at that date.
Chair,
Yes?
I think it would be useful.
Okay, we'll ask that they attend. Is there anything else, any other information that committee members want to support or consideration of the rule at the meeting on the 2nd of July? No? Okay, thank you. So just moving on then to item number 7, which is an oral briefing on Caleb's cause. Can I refer members to page 52 of the main pack? And now we'll just welcome our guests in. Okay, you're very welcome. Can I just welcome officially Miss Alma White, Miss Karen Ryan, and Mr. Alfie Lonergan. So you're all very welcome, and thank you very much for attending. All right, so we have received your contribution, so thank you for that. I'm just going to hand over to yourselves just for introductory remarks, and then we'll take questions and finish. So over to yourself.
Okay, so well, firstly I'll introduce everybody that I've brought with me today. It's nice to not be on my own. We have Jacqueline online with us, so she's going to be contributing as a parent as well, and we've got Karen Ryan, who's a parent. And we've got the amazing Alfie here, who's come along and agreed to come along and present also. So thank you for allowing us to come today and for letting us to present to you all. We have a mountain of things that we could say that would take days, but we're going to do our best to cover as many issues as we can, and there is a lot of issues. And there will be some brutal honesty as well, which you would expect from me, I'm sure. So we'll start with Karen and then
go from there. Nice to meet you all. Thank you for your time today. For those of you that don't know me, my name is Karen, and I'm here to speak on behalf of my daughter Emily, who is 17, and she was born with a rare chromosome disorder, so a genetic condition that doesn't have a name, and it's left her with a severe learning disability. So I live in the Lisbon area, so a lot of what I talk about will be with regards to the South Eastern Trust, because that's my own lived experience. And I'm here also to speak for those families within my SEN community who I know personally and I advocate for. And when I tried to make sense of what I was going to say today, obviously there's a lot of issues that need addressed. But every note that I made kind of highlighted the lack of collaboration between health and education departments. Do agree with Caleb's cause that all departments need involvement in the SEN debate, but the pathways to a better system of daily care when you require 24-hour care. For families like my own, these lie within these two departments, and this is why Caleb's cause is asking for legislation and a person-centred care plan. If I trip over my words today, I dropped my daughter up to respite yesterday. I know you're going to talk about respite later on, and I just, as it's Carers Week, just take a moment to explain to you that when a carer drops the young person to respite, their body switches off. I've driven the wrong way to the Children's Hospice to drop her off because I know that my care and responsibility stops. I don't take lightly being here today. It's a fantastic opportunity for me, but it will leave me emotionally drained. You know, I should be in bed in my pyjamas while I'm not caring 24 hours for my disabled daughter. So I just want you to bear that in mind. We're all carers here. This does come at a cost to our own mental health. So what has transitioning been like from a medical point of view? If input from health is only kicking in at 18, how can they advise on pathways before this? It needs to be much earlier and before they turn 16 when their mental capacity assessment is made. Why not save trust money and time and use the mental capacity assessment, which should be done before they're 16, so when they're 15 and before they leave school, as proof of a learning difficulty? IQ tests would then not be necessary at 18 to prove that a child transitioning to be an adult has a learning difficulty. Would you really put an adult with a severe learning disability or difficulty into the community without support? Without a children's disability social worker, the pathway to transitioning is almost impossible to navigate. And this comes with significant knock-on effects. I was concerned when I attended the South Eastern Trust talk back in March 2025 by Lorraine Node on how the Health Minister's finances from November 2024 were to be spent. It gave a fantastic explanation of how children's disability services were addressing the lack of a social worker team and provision of respite and support services. But it demonstrated then that there was not the identical input into adult provision for post-18-19. It was as if you're sort of front-loading those children's services and then, again, it'd fall off a cliff edge at 18 or 19. And that is what I'm currently facing with my own daughter. So she's 6 months left until she turns 18, and my respite will stop on her 18th birthday on February the 17th. And as a mother on her own, caring for not only my daughter but my two younger children, I need that respite. There won't be anything. Dropping Emily up to the Children's Hospice, I took my middle daughter with me, and she reminisced, we used to come here when I was little. We used to stay over, it was great. We used to play with those toys. She had fantastic memories of the care that they provided for us as a family. And knowing that that will stop next year is quite heartbreaking. There can be families who have an identical scenario to my own. A child with a severe learning disability, full-time wheelchair user, non-verbal, doubly incontinent and feeding issues, but without a diagnosis, either genetic or neurodevelopmental. They can exist in a system that does not recognise or track their needs. So again, from lived experience, is a family that attends the same school as my daughter, in the same department as my daughter, almost identical wheelchair users, medical issues. They were born with an injury to their brain at birth, so they don't have a neurodevelopmental diagnosis and they don't have a genetic condition, and they fall under the radar of accessing so many services because they are not picked up by the same system. There can be other families who have an identical scenario to Caleb's. A child with a severe learning difficulty, non-verbal, toileting issues, and with severe behavioural issues, a bit like the Spotlight mums that you would know or be familiar with their stories. They can exist in a system that does not recognise their daily care needs or plan for their future. Their needs for a social worker, their needs for benefits such as direct payments, in needs for services such as OTs, housing adaptations, respite and transport. LAC reviews have been the saving grace for my daughter in keeping everything documented and accountable from school, nursing and the social worker team. This has facilitated respite, which has a requirement of a yearly medical with a GP and an up-to-date care plan, so that if something happened to me, Emily could be cared for correctly in a nursing care environment. That's hugely important as a mother to know that she'd be cared for. A yearly medical recall for SEN individuals would assist in keeping track of complex health needs if they are not picked up under review by a paediatrician. When reapplying for PIP at age 16, the written response I got from the GP was to say that they get hundreds of requests for these forms and they don't have time to complete them. They simply sent me out a list of her current medication. Surely let's save the administration time and skip this process. If you have a lifelong health diagnosis, it means just that. It's lifelong, and PIP is awarded for life at a much earlier age. What happens to young people at age 16 if they have been to a SPIM? SPIM is a special provision in mainstream for their school life. How will they access the health pathway, especially when there is currently no statutory service for autistic adults? They will reflood the system at age 16 and there will be no school to do the prep or support the parents on what the next step is with the health department. Currently, none of this provision for SEN adults in my local area of Lisbon work well. If we spend roughly 15 years in education, then we should reassess where our SEN adults are allocated places, moving them on from ages 20 to 35, 35 to 50, 50 to 65, and 65 plus. We need to provide for them daycare services that are for their lifetime and be prepared for those who currently attend non-trust providers who will reflood the system at around the age 35. Some daycare opportunities are brilliant at developing skills, but the young people don't get paid and have no progression into employment. Other provisions sees adults doing 10 years of part-time filler courses, which are limited to no outcome. Then where do they go? The entire provision for those with a learning disability needs urgently looked at and needs to be held under the banner of health and social care. The Health and Social Care Trust, run at LARC, which is the adult unit in Lisbon, was good when it first opened 16 years ago. Great resources and limited number of clients. But what is their maximum capacity now? It says on their official brochure they take 120 adults. The manager tells me it's more like 80. This is due to a lack of currently 11 staffing vacancies. Tea service, which is an optional service that the social worker brought in, which allows the adults to stay after daycare from 3 until 7 p.m, was brought in about 20 years ago. It was 5 days a week. Then it was 4 days a week. They've now cut that provision to 2 days a week. And it's had a significant impact on parents that can now no longer work a full working day, and it's affecting their income. This has already had the knock-on effect for a lot of families. And this facility at Lark needs to be 4 times bigger for the Lisbon area alone to accommodate the number of school leavers coming up the way. It needs to have a specialist behaviour unit, a specialist sensory unit, a life and independence skills unit, and an elderly care unit. Transport to day opportunities which are not run by the Trust are being pulled. Only day centres will be provided transport. This will leave those families unable to transport their young person either in financial difficulty, from paying for private taxi hire, or socially isolated. So in summary, a lack of social worker, therefore no individualised approach, a lack of proper and appropriate provision, and a lack of forward planning. Please, would you take the comments that I've made, consider what you want to put forward, and if you have any questions afterwards, I'd be happy to talk. Thank you.
Thanks, Karen. So I'm going to speak openly and honestly as I try to be a voice for so many hurting families. To add to what Karen has said, I would like to highlight the extreme lack of cohesion between the 5 health trusts. Everyone is doing something differently. No one seems to collaborate. It's very siloed. Young people are being put through another barrage of testing to prove a learning disability at 18. Why? Why, when your young person has attended special school since they were 3 and often had these tests done early on, are we having to put our young people through this again? Why can we not have a more holistic approach? These tests can take months. If a young person has an IQ score that goes a point or so above, they are deemed to not have a learning disability. Despite low functioning skills, they are then discharged from the learning disability team. No services and no support. One family had this testing done only 8 years ago, and they are now being told that the young person needs this done again. They are currently in a special school and have evidence that on an academic level, this young person is way below average and has the functioning skills of an 8-year-old. This young person is currently 16. Surely mental capacity tests would save time and money. I fear the reason for the IQ testing to access adult services is another way of cutting provision. It begs the question, is this a person-centred approach? We are still waiting on the new learning disability service model to be announced. I have major concerns in who exactly this will include. If you cannot get a learning disability diagnosis, who will be able to access the services offered? What happens to those who don't have a learning disability, who fall outside that remit? Again, I fear another siloed model with more young people excluded. It begs the question, is this a person-centred approach? Caleb's cause has always been for all complex needs. Caleb and many others will never have an academic pathway, but this doesn't mean they are neglected, abandoned, or left behind. Caleb's cause wants an equitable care plan that is centred around a young person's needs, regardless of disability. Why would this not be a priority? In the long term, it would save money to have everyone under one umbrella, yet I am told no. There's no time. Really? There's no time for our most complex young people. The programme for government lists post-19 for the first time. We fought for that, but I fear it means nothing more than words printed to tick a box. What has the Health Minister done for post-19 complex needs in this mandate? It's a question that we could ask him. We are not experiencing any positive change in our lives or the lives of our young people as yet. It begs the question, is this a person-centred approach? Many families have shared with me that they feel the culture or behaviour from senior staff in the trust is quite frankly shocking at times. Parents and carers feel gaslighted, ignored, and treated in a way that causes unnecessary trauma. I have countless lived experiences from families who do not feel supported. In fact, they go as far as to say they feel judged and blamed for this situation that they find themselves in. The system does not work with us as parents or carers, it works against us. We beg for help time and time again. Communication is poor. Often there is hesitancy to respond to anything in writing, and we are left to feel ignored. Nothing is explained, and the attitude we often hear is far from empathetic. We are talking about families deep in crisis, families that struggle to get through each day with no respite and no emergency planning for immediate need. Why don't officials listen to parents? And I'm not talking about filling out a survey. Really listen to us, because we often bring solutions, but there's a culture that exists where parents are often not included and most definitely not supported. Parents who have young people that are identified to have 2-on-1 or 3-on-1 care are trying to manage at home daily, often with one adult present. Siblings in the home are not being safeguarded. How is this acceptable? Where is the plan? It begs the question, is this a person-centred approach? In the 2 years I've been doing this campaign, I have watched hurt and pain on a level I can barely explain. I feel angry at times as I watch our government sit back and let this continue. As the numbers increase, and they will increase, because I've just had the numbers pulled from the Department of Education to predict the next 5 years, and over the next 5 years they go up over 500. Currently this June it will be 300 leaving special school at 19. As the numbers increase, we are being ignored. When will post-19 for complex needs be addressed and acknowledged? Are we going to wait for a fatality before someone finally steps in? Today we are here to ask for complete honesty. This is the first step where change could happen. However, without transparency, things will remain as they are. It's time that our health minister took the reins and agreed to a person-centred care plan for those with complex needs leaving special school. We are decades behind other jurisdictions. Disability is lifelong. This is a lifelong issue and one that is not going away. Despite how we are often judged, as many parents are desperately trying to hold down a career so they can continue to work, we are asking for a plan to help us do this and to support our loved ones from the cradle to the grave. The fight is lifelong and we are all exhausted. We are here today begging for help. The question is, when will it come? It begs the question, is this a person-centred approach? So I would like to pass over to Alfie to say a few words. If you could all speak up for him as well so he can hear clearly when you're asking us any questions. We would like the opportunity for you to ask us questions because we are living this uncertain path every single day of our lives. And I think this is a time that you can get real answers and real honesty. So I'll pass you over to the wonderful Alfie, who's, I feel very honoured that he's here today. So.
Well, before I go forward, I would need to go back a wee bit. I became a sole chair on the 5th of September 1984 for my 4 children who were 10, 8, 6 and 1 day old. My wife passed away suddenly after Ronan, my youngest son, was born. The last word she said to me before she died was, "Alfie, look after the children." And that's a thing that's still in progress. Can get a bit emotional. My 2 daughters are here and they're happily married. They're 2 great husbands who would do anything for me. My son, Donald, is 48. He's autistic. He has OCD from birth. Ronan is 41 and has a severe disability, learning disability. It's fair to say that I'm on call 24/7. I go to a dance once a week to get the head cleared. I take my phone with me. I'm liable to call and say, "Listen, there's one of the boys here and he's a bit sick and he was asking for you where you were." So I would go home at that stage. My daily routine is I rise around 7:30. I get the boys up, get the breakfast sorted, attend to Ronan's personal and practical tasks. Their needs ranges from being sick during the middle of the night to headaches, to making sure they're taking their medications, showering, tying their laces. Donan's autistic. He needs the laces tied 5 times in the morning before he moves on. He's, I suppose most of you know about autism. He has to do something a number of times before he can do the next thing, you know. I take them to the social appointments, barbers, social groups. I was at one last night with them, a great wee group in here called TAG. I listen to their repetitive talks at night, which is, it's not fair to say it, but it's shallow, you know, and it's, I suppose it can be hard to cope with, if you know what I'm saying. And I be very patient. Luckily, I'm a patient person. My sleep patterns get disturbed badly. One of the sons that has the autism, he's very cheerful, but he wouldn't go to bed maybe 2:30, 3 o'clock. He roams about the house and he's opening a door, stands a while in that room, goes to another door and stands a while there and closes it. And that's a sort of a pattern he does. So I get a bit of sleep usually during the day. Physically, I'm in great shape, thank God. Emotionally, down the years, there was times when I was holding on with my fingertips. Lately, since 223, the pressure got desperate. For 20 odd years, the trust supported me in the morning with the package and that, and I had great, every chair that came through my door were excellent. But I was very, very thankful for those years of support. November 1923, the package for Dolan was reduced to 1 hour in the morning, and Ronan's was taken away completely. Myself and my 2 daughters battled with that since then, and the constant, and MPs of all parties worked for me, and the MPs got the same answers as I was getting. We have no workers. So after listening to that for 2 years, I said, but I tell you, that's your problem, and you have a big team to sort that out. I have my problem, and there's only me to sort it, you know. To fast forward 16 months, my daughter Rushing received a call from domiciliary care to say they were taking the last wee piece off Donald. That left nothing. I had warned them several times, had umpteen meetings with them, with the trust. And we had said several times, we'll have to do something about this, for I'm going to crash, and it'll be your problem then. And they says, well, do whatever you want to do. I had no option, only go to the Stephen Nolan show. And that moved the thing on because they gave me an hour back, 1 hour. And that's very insecure. I could get a call any morning to say the hour's gone. They can't give me something concrete about it. And it's not enough anyway. I think I said at the start there, I'm 85. And well, that's nearly the roundup. I got that hour back. Mentally, it's since 223, it has had a devastating effect on me mentally. You know, because after COVID, I would phone and see, have anybody tomorrow, and they'd say, we'll phone you back. That never happened. Phone you again. Who were you speaking to? I hadn't taken a note of it. I don't know who it was. Well, we'll get somebody to phone you back. Never happened. Sometimes a week at a time, I had nobody. So it was slipping so bad that I had to do something. But anyway, the pressure of it this last few months has really, really knocked me, and I wouldn't like it to keep going. Thank you, Tim, for listening.
Thank you very much, all of you. That's a pretty shocking assessment of where the situation is within our care system, what should be our care system. To be honest with you, I have had a lot of questions that I wanted to ask about transition, about the impact on families, about the differences between all of the trusts. To be honest with you, I actually don't want to ask them now. What I want to ask is actually solutions. So, I mean, if there was, I mean, we're all as disappointed, Alma, as no doubt you were, or as you have expressed you were, when the Minister knocked back legislation or inquiry and taking this forward. I mean, you certainly had the support of all the members in the chamber. So that was a disappointment. But in terms of solutions, so if 3 things could happen today to make this better for you as carers, for families, but more importantly for your children and the people that you're offering support for, what would those 3 things be?
A care plan, a lifelong care plan, underpinned by laws that don't take it away. I think one of the biggest problems we have, and Alfie is so brave to speak out because it's really not easy, and you know, I really wanted Alfie to come today because he shouldn't be sitting fighting at 85. We've got Jacqueline, who's the mum of a younger child. We've got Karen, is the mum of a 17-year-old, 18-year-old, and then we've got Alfie. And I wanted the picture to be shown in its fullest, just how much of an impact this is having. I think it has to be a care plan, because the problem, I think, what really worries me the most is exactly what's happening to Alfie and his sons, is that no one's tracking. No one comes to your door looking for you to say, are you okay? Do you need help? Alfie is very much still clinging on to what he has, and I don't think he's asking for very much. You know, and I think also, as you know, when you're an older carer, you have saved the health trust thousands upon thousands in caring for your loved ones. This is what we want to do, and you won't give us a care plan, and you won't underpin that by laws that will give them a future. I don't understand that. Is that human? Is that where is the human rights in that? There is none. So yeah, I find it very offensive and very hurtful that it was a no. I think officials are advising the minister wrongly.
And does it need to be underpinned by legislation in your view?
It does.
Okay.
You look at the UK, you've got the Care Act that underpins my nephew's Care Act assessment plan, which is 27 pages long. And everyone can say there's parts of the UK it's not working. Let me tell you, there's parts that are. They have a court of protection. They have continuing health care. He has an ID number. He is tracked. There's a multidisciplinary team involved. He had a specialist college that he went to. He has 2-on-1 care. He has medical needs. He's in residential care. There are parts that are working. So that cannot be an excuse. I'm sick of the excuse. It's complex. It goes, you know, we're ping-ponged between departments. Our children are just passed around like a ping-pong ball. That has to change. And we've already seen Kiva Archibald bring her piece to the puzzle through economy for those that can access further education. Our children with complex needs leaving special school will never have that pathway. They'll never have that pathway, and we need to start being honest with what that means. So should they be left on a scrap heap with nothing? No. Are they part of society? Absolutely. Should they be treated like human beings? Yes, they should. So I very firmly stand by what Caleb's Cause is asking for. The manifesto, you've all seen. It has to change because, like I said, Kiva's brought that one piece of the puzzle, which has come through economy. I really hoped that the minister then, I really worked hard on pushing for that, because actually that is going to cover a large portion of young people. The portion that are left, the numbers are in the hundreds. 300 are leaving special school. Even if you had to backdate that to older people that are in our society at the minute, you're talking hundreds, not thousands, hundreds. And you're telling me you can't do that. So yes, I am, and I'm going to keep coming back, and I'm going to keep bringing people, and I'm going to keep bringing the stories, because it's wrong, and everybody in this building knows it's wrong, and it needs to change.
Apologies, Jacqueline, I didn't introduce you at the start, so you're very welcome to the meeting online as well. So I said I wasn't going to ask questions in typical politician fashion. I'm going to go back on my word. So just when you were talking there about the legislation, so transition is obviously key. At what point is it breaking down for families here? You know, is it?
Many families aren't getting a transition. So some are.
Yeah.
I know that it depends on the trust, depends on the situation, depends on the young person. For example, I'll bring my situation recently where Caleb was an SLD child that back when the library boards existed, he was put in an MLD school. He was in nappies, he's non-verbal, he's predominantly still non-verbal despite him being able to read out loud. So his functioning skills are very, very low. He was put in that school. I didn't know enough. I didn't know that there was a difference between a difficulty and a disability. A difficulty is listed on their statement under education. When they get to 18, your young person then has to start all over again and go through and prove that they have a learning disability, because that means lifelong care. So to access adult services, that's what you need to do. So unfortunately, if you have MLD, sometimes on your statement, there's a real push, there's an assumption made that your young person maybe is more functioning than what they actually are. And so I've gone through it with Caleb now, and thankfully only in the last sort of week we've proved he has a learning disability. He's been under the learning disability team since he was 4. But to put young people at 18 through a barrage of testing for months at a time, I know parents that said it started in January, ended in November. It's not really a person-centered approach in my mind. So I think mental capacity, if you're, during that transition phase, health needs to be involved at least at 16. Because really, all the departments should be involved. There should be a leaflet, there should be communication that says, at 16, apply for this. At 17, you should be doing this. We're not told how to get a bank account. We're not told anything until it happens. And then you're scurrying going, I need to do this. He's an adult. I'm sitting with an adult at home who hasn't had a mental capacity assessment. So what happens if I need to take them to a hospital? Nobody thinks. Nobody, the worry and the fear and the anxiety we have as parents. So, when do we say, at what point do we say this has got to change? But that transition is key. And all those departments, I'm not saying that every department needs to come to reviews, but you need to be aware, you need to have a leaflet to say your department is responsible for this. Every department should know what they're responsible for. I'm not convinced they do know. And so that parents can plan and prepare before 18, because as soon as you get out of school and that 19, that cliff edge, education go, not our remit, goodbye. And then you're going, okay. I remember saying, well, who do we go to? Do I phone? Well, no, because you're not our remit. Economy will say, well, you don't fall under us because you're a health path. And health will go, well, we've got, we haven't really got a system as such set up for, you just have to wait. There's a parent that contacted me recently and said that their young person has been on a waiting list to see, to get a learning disability diagnosis since, he's been on the list since 24. She rang the other day and they said, we're only working through 21, 22 at the minute. So what's happening? They're not getting any services. So young people are sitting at home. I keep reiterating this. They're sitting at home with nothing. This is what we are doing as a country. This is what we're feeding.
I chip in about my perspective. Obviously, Alma's son has a learning difficulty and my daughter has a learning disability, because she's severely disabled and medically diagnosed. But all the information I'm pushing the social worker for, it's not forthcoming. So I'm sort of, because I know probably more than the average parent, I'm asking the questions. And because she accessed respite from the age of 8 or 9, I think it was, she goes for 2 nights a week at Forest Lodge, and that works really well for her. But she's picked up under LAC review every 6 months. And that's where I'm able to link in with the social worker and ask the questions. But if you're not under that LAC review system, your access to a social worker is zero. Yeah. Unless you're ringing them every day to ask them to be on their caseload. So then how do you know about transitions? On my last LAC review in March, I asked, when do I get to meet the adult social worker? And they're like, oh yeah, right, okay, we'll book that in for September. I'm like, but Emily's 18 in February. I need to know about respite. I need to know where she's going to go for post-19. Oh, well, that will be the first opportunity you'll get to speak to them. And there most likely will be a gap in respite care. So respite will stop on Emily's 18th birthday, and it's likely to be a gap of a minimum of 1.5 to 2 years before she will be offered respite. And the nearest respite to my house is a good distance away, Ackley from Lisbon, whatever that is in miles. There isn't one in Lisbon that would suit her care needs. As to her post-19 provision, the unit where there's only one unit that she can go to, which is LARC in Lisbon, and it's already full. So they will not be able to offer me 5 days a week. She will go from having 5 days a week at school to either 2 or 3 days a week at LARC. So what am I supposed to do with her at home for the other 2 days? That is what is not being told to parents. They are not being told that if they have any kind of medical issue as a child, if they need medication, if they need toileted, if they need their feeding regime done, if they're tube fed, if they're behavioural, that they can only go to a trust-based facility at post-19. They are not being told that early enough in the transitions process. They need to be told that from age 14, which is what I raised at the Education Committee last week. So parents are going into this completely blindly. Yeah. They're not allowed to prepare because they don't have the information.
Yeah.
Jacqueline, you wanted to come in?
Yeah, I was just going to do it. I wasn't sure if anybody was seeing the Zoom, but yeah, I'm Dr. Jacqueline Horan. I am in Derry, so I didn't feel a bit safe to travel today, so I was hoping to be there. But I am a mother of, as Alma said, a younger child. She's 11 and she goes to special school and she has a severe learning disability. She's also nonverbal and she has an eating disorder, which is also quite difficult because she doesn't eat when she's at school. And she follows a very, very strict routine. So any disruption to her routine, like I'm dreading the day where we have to stop what she's doing and have her reassessed and go through all the same processes because we know she just won't be able to deal with that. Until I met Alma and joined Caleb's cause, I didn't actually realise the extent to how things happened. I have 2 older boys who both attend grammar schools and will have the usual career path set out in front of them. And to think that my daughter, who has been known to the health service, to be known to education since the age of 2, that she is just going to be taken at the age of 19 and put back into the general population as if nothing has happened for the last 19 years. It's absolutely shocking. And I have kind of worked in the background in this campaign and haven't spoken up until this point because I didn't want to derail the focus away from Alma and Denise and Karen and Alfie who have older children. But parents of younger children do need to know this. They need to know that they are going to be in that position very, very soon. And my daughter's starting first year in September, and as anyone with children knows, the years just fly by, and something does need to be done. I've taken time off my job this afternoon to be here, a job I love, and a job that I don't want to have to give up when she leaves school. And she receives respite at the moment, which greatly helps me function because I would also not have my weekends to myself for me going to work as a break. And I'm very fortunate to be able to still keep my job because many people in the charity that we're part of, many of the parents, or at least one of them, has had to leave their job, and sometimes both parents. And I did read a statistic a few years ago that only 11% of parents of children with disabilities had both parents at work. Just in terms of a point that someone brought up earlier about the health service and having to constantly give information over and over again and get reports to prove that you're entitled to benefits. I had 2 box files, one A to Z files. One was for the whole family and one was just for Aoife, and that one was bursting at the seams. And I've actually had to buy a filing cabinet because the amount of times I've been asked for these documents over and over. I can't let any health professional discharge her because if they do, I won't have any evidence and I'll be told, well, there's nothing wrong. She doesn't have a medical condition that can be treated. She doesn't take any medication. but I've had to keep every single professional. She has to stay on their books, and I have an annual review on the phone usually. So I get a report every year. If I didn't have those reports and look at the amount of time and the amount of, at one point we had 45 professionals involved in her care, and every single one of them I have to meet annually to get a report that doesn't really need to happen. If she was awarded lifelong care plan and also awarded her benefits for life, because when I submit these things each year, nothing ever has changed, and it's actually really upsetting. And I get really upset listening to Alfie. Alfie's amazing, and thank you so much for being here. And the reason I get so upset is because I think we all can just see a glimpse of our future. So sorry, you were asking about solutions, and that's why I kind of came in, but I just wanted to introduce myself. The fact that support ends just when school ends means there's no crossover period. There is no incentive for anyone to do anything. But if we had something in place in England with the HCP, because it runs to 25, there is a crossover period where somebody has to get involved and somebody has to do the transition. And if we had something like that, sorry,
All right.
that would naturally lead into a care plan, because for those who need it, we don't know who needs a care plan leaving school, and perhaps the fact that we have to keep justifying ourselves over and over again is the problem. But if we had something that lasted till at least 25, and at that point we assess for a care plan for those who need it, then that would nearly force some kind of something to happen within that crossover period. Having children leave school and education end, I work in data. I'm a data scientist. I'm a chartered statistician. I've asked for the data on SEND and been told that the word SEND does not exist in adulthood. It's an educational term. So we lose our data, we lose our records, we lose our care, we lose our support, and everything just goes. And another department picks up who know nothing about our families. So I think a solution is just to force something immediately that is till 25 at least, in line with England, which I don't even know why we don't have that anyway. And then from that point, we have a care plan. Thank you. That's all I have to say.
Thank you very much, Jacqueline. I noticed you wiping your eyes during Alfie's evidence. I think it was something we all found extremely hard to listen to. I actually have a question for you, Alfie, if that's okay. So, you in your experience, you talked about the care package and the care that was there to help your sons, and then it was reduced, and then you had an hour, and then that was reduced. What was the reason for the reduction in the care that you were given? Is it because of geography? Was it because of your son's age? What was the reason why that was all reduced?
The reason I got, and the reason the MLAs from all parties got, was that they had no workers, couldn't get staff.
And is that because where you live in a rural area, or?
Well, I'm halfway on the main road between Newry and Armagh, and I don't think it's really classed as a rural area.
And I'm just asking, sometimes care packages are hard to get because of people living in rural areas. That wasn't the case.
No, that wasn't the case. I understand that, yeah.
Okay. No, I just wanted to know that. I think that's an important point in terms of workforce and having proper planning for all of society's needs. So I'm just going to move around now to other members. Danny?
Thank you, Chair, and thank you all of you for those presentations. They're incredibly enlightening, and they show us the pressures that your families are dealing with on a day-to-day basis. It's unbelievable that you've had to deal with this without support for so long, Alfie, and I'm horrified that the support was taken away and then brought back in. Even that little tiny bit, that should not be the case. I think you're fantastic at what you're doing for your sons. It really is phenomenal, but you deserve that support to be there. And it should be there lifelong. And I'd see the progression of today's presentation, that we do need to address this now, so that those other young people and children don't end up in the same situation where that support isn't there for them and for their parents. But you're doing a fantastic job. It's. Thank you. I'm struck with the economic bad forecasting. This does not work economically. You know, the care that would be removed from yourself, if you were not able to care for your sons, it would obviously have to fall on the trust, and, you know, it would have to go into probably residential care, which, you know, is a lot more expensive to the trust anyway. So there's a lot of financial issues here as well. You know, putting in a cheaper form of care would obviously prevent a lot of extra cost coming down the hill, and certainly with the young people as well. It doesn't seem to make sense to me. I noted from the letter from the Minister to Alma, just that the Minister was looking at legislation about the Chronically Sick and Disabled Persons Act. Do you see that as a route that we can use to progress change here?
To be honest with you, it's like you're constantly trying to find a way to get something. I think it needs to be updated. It's I don't even know that autism existed when that was written. It's nearly 50 years old.
1978, I think.
Yeah, it's many years old. But it does pertain to the demographic of who we're talking about here, because it says about a lifelong plan, and you know, you're talking about every area, housing, you know, all this needs to be planned for. I know we have families who aren't getting respite, whose young people are seen to have extreme challenging behaviour. They're getting reduced timetables at school. They've been promised respite and they're not getting it. And I am really, really concerned about safeguarding for the siblings in the home, for the parents themselves. I think something's going to happen. And then it's a case of, do we have to wait till something happens before we step in? But who is monitoring that? Who is overseeing all that? But I think the legislation needs to be updated. It needs to be brought up to date. I know England has the care plan from 2014, the Care Act plan, sorry, and that's really good. And it underpins, like I said, my nephew has a Care Act assessment plan, and I mean, I've seen it because I helped fill it out with my sister and the social worker, and it's dramatically different. I mean, it's a care plan. It talks about every aspect of his life. What worries me too is that you could type in Caleb White after 19. Does he exist anywhere? What records have we got? I mean, I'm at the minute going, Caleb's now 18. Do I phone the GP and ask for authorization to speak on his behalf? No one's told us what to do there. We're just left. So, you know, I can't even imagine what it must be like to sit where Alfie is, to have to keep, you know, you feel like you're with the begging bowl, you know. And actually, I think I've listened to an interview that Alfie's done in the past, you know, where, and it really struck me, and I thought a lot of parents, it will resonate with them. We're made to share all the negative things about our children and young people. We never get to share the positives and how wonderful they are and what a gift they are, because you spend your time having to be so negative on these forms to get any help that you can. And you're almost afraid to say, he went to the toilet by himself today, because they might take something away from you. So that's the fear we all live with.
It is, of course.
And I don't know if you want to add to that, just how you feel, but I know you're very proud of both your boys. So
I'm very proud of the whole family.
Yeah.
The only thing I wanted to say was the Trust wanted an assessment done and it's completed there about 3 weeks ago. I didn't really understand the reason for it, because they said to me sometimes the people improve as they get older. Well, in my case, that didn't happen. There was no miracle, you know. So I couldn't understand the reason for it, but it's gone anyway.
was it occupational therapy assessment that you had to have? Yeah. It's just these constant assessments throughout life, and you kind of look and you go, what is the point in this? It's very obvious. And I will say this, back to the mental capacity. If you're a young person at 14, 16, 18, 20, 30, 45, if they don't have mental capacity, they don't grow it overnight. It's not going to come back. if you don't have mental capacity, you don't have mental capacity, and there should be a care plan in place. You wouldn't put someone who has dementia with, who doesn't have mental capacity into the community with no support. It just doesn't make any sense. But these constant assessments to have to jump through hoops to keep proving that you're eligible for what, an hour Alfie's asking for? It's humiliating. And it's also very stressful on our young adults who have to constantly be prodded all the time. No one, again, not a person-centred approach.
And I think, I'm not sure if it was yourself or Karen had pointed out, that the amount that this is saving trusts, thousands and thousands of hours of care. We should be supporting carers as much as possible. I would say your events, and I've been to quite a few of your events, they do celebrate the positive things that your children do, and I think that's fantastic. And we've seen, songs, and we've seen reading poems and things, and it's really positive events, and I'm sure other members that have been to them as well would say the same. I find it bizarre that we know these children from a very young age, and I think Jacqueline has said since 2, known to the Health Trust, known to education, but we still don't have a plan for them once they finish school. I find that absolutely unbelievable. I'm very worried about the children that you said who don't meet the eligibility criteria. So there's obviously a threshold, and if you're slightly
so if you hit borderline, if you're 70 or above, 70 is the cutoff. I've had a parent recently, I think I shared in the education committee, Sheree Slangen, whose son Callan, he had been to, he's been known to services and got input and different things, and he scored 74, but I've seen his report and it says he's below average in every other area, 4 points over, and she has no support for him. And he's been expected very clearly, Jacqueline was saying, back into the community, he's never had any issues. And you're kind of going, this just doesn't work. And actually it ends up costing more down the line, because you're then accessing mental health, because, there's young people unfortunately getting into trouble with the police because they're very vulnerable. They're ending up in prison. I've heard it's now 1 in 5 that are in prison with a learning disability. Where are we heading? When it could be prevented.
The marker used to be, the IQ test used to be 85
That's right.
around about 20 years ago, and then it got lowered and lowered and lowered to diagnose a learning difficulty.
It's not a holistic.
70.
Yeah, it's not a holistic approach. And no matter what way they say, sometimes you'll meet and they'll go, "Oh no, we do look at everything," and I'm like, but you're really basing it on that score. And I do feel a little bit like it's a way of being able to cut services.
Yeah. It's an arbitrary cut-off just to gatekeep services, and I have seen it happen over and over, where how do we save money in this service? We'll just put this cut-off point lower, and that'll cut our numbers and that'll make things look better. And it's the families that have to feel the effect of it. And in terms of what I'd said about my daughter being known since the age of 2, she's 11 now, but I recently was sent a report from another parent whose daughter is 2, and when I read it, I was so shocked, because it actually I went and dug out of my filing cabinet Aoife's report, and I sent it, and I said, look, these look identical. And even to the point of how they opened the report, it was lovely to meet Aoife with her parents today. It was opened exactly the same way, everything in it. And I just thought, how many of these children are already known? See, at that point, the paediatricians are making a decision, and they're making a referral to educational psychology. My daughter got into a special school at the age of 3, and she didn't get a diagnosis of a severe learning disability till the age of 5, because they won't do it until they're 5, because that's another arbitrary cut-off point. But how did she get a place in a school that's for severe learning disabilities when she didn't have a diagnosis? Because they already knew. And how many children are known at that age? And one of the things that could solve this is having those data sharing agreements between health and education, and allowing the data teams to make those predictions and make those forecasts.
Thank you, Jacqueline. Thank you, Chair.
Thanks. Orlia?
Thank you. And Thank you so much to Jacqueline, Alma, Karen, and last but not least, Alfie. We really do appreciate, because I'm just conscious before you all started to speak, you have travelled from your homes, you could be at home resting, you clearly have your hands full in your own personal life circumstances with your beautiful children. So thank you for being here today and for giving us your time to explain to us the different issues. And I'll try and narrow it down to a few questions. So the most striking thing I think that you said, Alma, was the comparison with the correct assessment plans that are in place over in England since 2014. Is that correct? Mm-hmm. So am I right in saying with those plans, is there a process for transition, or do those care assessment plans cover the child from child to adult, so you don't even have to be talking about a transition?
Yeah, no, there's definitely a transition. So at the end of, for my nephew, he would have had an education and health and care plan right up until he was considered an adult. And then at that point, it was the transition to look at what does he need for the rest of his life. The care plan that we completed at the end, it's like an assessment tool that it sounds really weird. It actually has an algorithm that will give a care package amount depending on the needs of what that young person has. So he was allocated an amount according to his need. You know, he needs 2-on-1 care in the community, he needs 1-on-1 care everywhere he goes, really. He's incontinent, he's got various other health issues, but when my sister actually was diagnosed with cancer, then we had to look at residential care, and it was getting the right residential care, but the system and the framework is there. Mm-hmm. So I think the difference in Northern Ireland, which I see, is you know, a lot of it is put back on parents here. Now, don't get me wrong, it's still on parents in the UK. But with my sister, when we were wading through it, we kind of knew who to contact. Mm-hmm. You still fought, but you knew who was there, and everyone seemed to know what the conversation was. You know, there was a team. Whereas here, the exhausting part is you're saying it to one person, and then you might get a phone call the next day and you're saying it to someone else, and then you're not getting anything in writing, you're getting it in phone calls. As Alfie said, he's expected to then take in what's been said and remember it all. Mm-hmm. And so, you know, I think there's a massive difference. Yeah. There really is a massive difference. And I actually would I would be very happy if I could I have my nephew's Care Act assessment plan, I have my sister's permission. Mm-hmm. If I could black out some of his information, I would love you to see what it looks like.
Yeah, so that was actually one of the points that I was going to make. I'm not sure that, because I know obviously you've engaged with the Minister and the Department, if you have had any direct engagement with him on, you know, this sort of model of best practice potentially that's happening over in England, and if he's aware of that, and I think it might be worthwhile for the committee maybe even to try and get a research paper done on this around what models of best practice are out there. If we can look to that model in England, if it's one that already works, there's no point in reinventing the wheel, even in the case of holding an inquiry here to say what's the outcome going to be. If Alma, because surely with your experience and all of your expertise on this issue, because you have lived it, you have walked this path, and I would say it's one of these issues, probably unless you have walked the path, it's hard for us even to comprehend the real true reality of living like this and having to fight your whole life for your kids and the services. But if you're convinced with this model over in England, then I certainly think it's worthwhile us following up with the department even on that alone to say, have we given this any consideration? Can we get a bit of research done around this in terms of how, you know, appropriate it might be, or the potential of introducing it here? And then my other question was around the cost of potentially implementing this model. So you mentioned the 300 school leavers this year. The department have confirmed that's going to be 500 in 5 years. Mm-hmm. And have you obtained any sort of, like, what cost are we looking? Because we know cost always comes up, and with the department not having, you know, having a very constrained budget, do you have a sense of what cost, if we were to try and implement something like that, what that cost would be? And then my final question is around the NICE guidelines. do the NICE guidelines, excuse me for my ignorance for not knowing this, but do they have specific guidance around this whole issue of post-19 and what services should be available? Because we know that our department obviously follows the NICE guidelines, and that's the right thing to do. And then I'll just end on this comment. I want to thank you, Ethan, for giving us the different perspectives from each and every one of you that are here today. Alfie, who's lived it his whole life with his sons, and Karen, your daughter, who's about to turn 18 in 2 months' time, and then obviously Jacqueline as well, coming from then the parents who are living with the whole fear and anxiety of facing the cliff edge that you have already faced and went over.
Yeah.
So that has actually really meant a lot. It's given us a very, very good perspective, so thank you for that. So just on about the cost, and the NICE guidelines.
Yeah, I think, you know what, the first thing I'll say, and then I think I might pass to Jacqueline, so she might be able to help me with this one, but one of the things I will say that I've kind of hit a wall on, and I need you to understand as a committee, I can't even get that far with the Minister. So with regards to any scoping exercises, I can't even, I'm met with a bit of a brick wall at the minute. Mm-hmm. So it's a case of no, we've no time, no, there's no resources. I will give up my time and I will give you what you need. I will get the information, I will provide examples. I am bringing solutions. Mm-hmm. I will quite happily come here and sit and write out whatever you need me to write, and I will do, you know, if it moves this forward, because it's going to help thousands of families out there. And I just don't know where he is with this. I kind of thought, you know, what a legacy for any minister to be able to say that they implemented this. I don't know that we're there yet. But Jacqueline, I don't know if you can pick up from just the costing and stuff. We would probably need to go away and probably look at that.
Yeah, it would depend on the level of need. So care plans, by definition, are individualised. So it would be individual per child, depending on how much they would need. But if you look at the funding structure in England through the EHCP, children who would be in mainstream and would have some support could be potentially around 10,000-20,000 a year, depending on, you know, what's provided. But they also have specialist day colleges that we don't have. So those are typically, you could be talking 25,000, 60,000 plus for those, but those would be for the children with the most complex needs. And then you've got packages where at the moment, when we have a child that goes, or a young person that goes to a day centre opportunity, they can have a place funded, but they can't have a one-to-one assistant funded as well, because that's counted as double. So that's something that would need to be considered as well. And I think that costs per day at the moment, it's 110, Alma. I think. So if you were to double that, it's be 220 per day for a 5-day week. So those are roughly the cost, but we don't actually have those types of colleges, so it would probably be based on the direct payment system that we currently have, plus the existing day opportunities. And I think that's one of the most important things that parents are coming up against. There's a place, but we can't send them because they can't go to the toilet themselves. They would leave, they can't eat, they would try and leave the building if you take your eye off them. So that's definitely to be considered. In terms of the NICE guidelines, there's a few areas. So there's transition to children and adult services, and that kind of comes under the Children and Families and Care Act that Alma mentioned already. They've got 3 areas. So then there's the disabled children and young people up to 25 with severe complex needs. So that would be the area that we're talking about. And then they've also got quality related standards. But as Alma said, I'm also happy to give up my time. I'm happy to put together costs, figures, reports, stats, data, policy documents. I'll even write the legislation.
Thank you so much.
Thank you. Just to let you know, if 3 more members have already indicated, and we'll have to end this for our next session at 1:45. 4 more members. And Colin, you're next.
Thank you. And look, thank you for your presentation. I think the information that's in it is one of those ones that we often hear, and it's so difficult, and that is where it's perfectly logical to do the things that you're asking to do, but it doesn't seem to be happening. And without getting political on this, and I include myself as other politicians in this, Alma, I don't think I've ever seen a campaign as good as yours. It's consistent, it's regular, it's persistent, and it's to the point. But you're still having to come back and back and back and back again. Yeah. And I'm just wondering, are you hearing warm words from the decision makers, from some of the politicians even? Or do you actually feel that you're making a change, in the sense, do you feel that a change is impending? Or do you feel that you're still walking in treacle and banging against a closed door? Because I think it's important that we acknowledge that because after you leave through that door, we will have to write letters and follow things up. And I don't want that to be just something that we do that's just a perfunctory task and we do it. If you feel that you're not getting the progress that you want or that you would like to see, I think we need to reflect that in the correspondence that goes to all the ministers, because it is cross-cutting across the departments.
I think, thank you for that. Yeah. That's really good of you to bring that up. I think what I am really grateful for is the fact that it's the first time this campaign has brought post-19 into real highlight. Mm-hmm. That's not to say that other people in the past haven't tried and do love them. It's exhausting. I'm a bit like a bull in a china shop, you know, once I get my head around, and I'm very injustice and, you know, which I didn't really know that till I kind of took this on. But I think, yes, there is tremendous support cross-party. I think the problem I sometimes feel is ministers. You get so far up the chain and then all of a sudden the door kind of shuts. Do I think I'm getting closer? I think it's being talked about. I think that the Education Committee, committees such as yourselves, do I think you care? Absolutely. You've welcomed me with open arms several times. You're quite happy to have me come back and you know, and share and bring people. So yes, on that score, it's really positive. Do I think we should be moving forward? Yes. I want a commitment. I want a commitment that is led by the Health Minister that says, do you know what? Yes, we need this. Acknowledge it. At the minute, I have a brick wall. I'm kind of at the point, and I'll be really blunt, is it a case of I have to now wait for the next minister? What a shame to have to wait a year and waste a year of all of our time, a year that our children are getting older. I can't emphasize that enough. Every day is a day that their lives are ticking on, and it's a day of worry and pain and exhaustion and fear. Fighting. So a year may not seem a lot to people in this building. A year is a long time for us. I'm 2 years into this, and I think we deserve more than that. And you know, I also feel I'll go as far as to say I think everyone in this building should be pushing this. I think everyone should be putting pressure on the Minister of Health, and I think that it needs to be done, and I would feel very positive if there was a commitment to drafting this with a care plan. I would feel like we're starting to move forward. But yeah, thank you for asking that, because it's...
And thank you, because even what you've said there has given me fuel for what we can do afterwards in terms of how we frame what we ask from that. So thank you very much for that, and thanks to everyone. Thank you, Chair.
Thank you. Can I just say something?
Yes, of course.
I just wanted to say in regard to that the response from all the MLAs from all parties was the same with jointed workers. My daughters wrote direct to the Minister of Health. His report was exactly the same. You know, that's what I want to say. So it's a stonewall type of thing. Thank you.
Diane?
Yes, thank you, Chair, and thank you to everyone for the presentation today. I've met you, Alma, on many, many occasions, and I've met Alfie as well. And I just think it's a pity that you have to keep coming back and coming back. It's good that you do, but it's just a pity that you have to keep doing it because you feel that no one is listening. There's a couple of things that I do want to ask. I'm sorry, just to finish on that. I hope you realise that I do think the Health Committee is listening, and we will discuss some of the things that we should do after your presentation. So it appears to me that when you have a child with a learning disability or any disability, Children's Service is reasonably competent at looking after that child. They go into special educational services and schools, and they are often wrapped around by love and concern, both for you and...
Oh, no. I've lost her. Keith, well done. Oh, sorry.
Just apology. I presume IT, I know that's a problem our side or
Back in a second.
Diane's side. Just we'll give her a second to see if she can move. Actually, I'm going to move to Alan Chambers, sorry.
Right, thanks. Sure, I don't have any questions, but I'm just going to get things off my chest about all this. Today has been a school day for me. Okay, I've learned a lot today. I think the thing that I realise and reflecting back on things over the years that I've heard and seen, it's not a new problem. It's just you guys have brought it to the forefront and made us all aware of it. But this has been going on for years, 25, 30, maybe it goes back 40 years, this vacuum of transition. And we have seen the child care, we have seen it improving, and it is a pretty good model. I'm sure it has its downsides, but it's a pretty good model. But just get to 19, nothing. And what I'm seeing today is that the broad spectrum of families that it's affecting, you know, with Jacqueline with a child of 11 and knowing that 19 is going to come around, it does come around, and her life is going to be dominated for the next number of years, thinking about that, worrying about that, working up, sleepless nights. Karen, you have 3 other children, and I think you said you were single parents, so you know it's going to impact on your children. You know, you're going to have to give more and more and more attention to the one with the special needs, and the rest of your family are going to suffer a little bit from that. And Alfie has spent 40 years of his life at dealing with this, so it's right across the board. And what it brought back to me was a case that I wasn't in politics and wasn't involved with. It's just a lady I knew in Groomsport, and she was in her 70s, and she had a son who was in his late 40s, and he became aggressive, and she suffered quite a few blows from him because of his aggression, just because of his condition. He didn't know what he was doing. He didn't mean to, but that was the reality. His mother was getting hit by him and stuff, and she fought and fought to keep him at home because she was on her own. She had no other family, and she was caring for him. And she spent her twilight years worrying about the future of her son, not about herself, about her son. And eventually he had to go into Muckamore, and we all know the bad stories around Muckamore, and I'm sure back in the day when he went in, he might have been in the middle of all that. And she lived for about another 4 or 5 years while he was in Muckamore, and she went to Muckamore twice a week to visit him. A long journey. She went twice a week. But that woman was tortured. No quality of life. Her mental health affected by the worries that she had about the care that her son might or might not be getting. And she knew nobody could give him the care that she was giving him. But it just got to a point where she had to hand her son over to the authorities. So it really is, and the reality, unfortunately, today, you know, we're all very sympathetic. How could you not be sympathetic to hearing these stories? But the reality is that it's a huge problem. I know you talked to it's hundreds and all. It's a huge problem, and it's going to require huge solutions. And we're maybe all looking for overnight solutions, and it's not going to happen. And I know that there are things that could be done, like Alfie's only an hour of care, and he's deprived of it. And that's only an elastoplast. That hour's only an elastoplast. But it may only be an elastoplast. But it was a solution for Alfie. It was a lifeline for Alfie, and it did give Alfie that bit of hope and that bit of respite. So it is, we've really got to start the solution, finding the solutions and working at them. But I fear it's not going to be overnight solutions. But we've got to start. The journey's got to start, and I think you people deserve that. Thank you. Thanks, Chair.
Thank you all. Dan, apologies. I don't know where the technical fault lay, but you're back with us now. So if you want to pick up where you left off.
Sorry, Chair, the technical fault lay firmly with me in that I ran out of battery.
Sorry, not you personally, Dan, your computer.
I
don't the laptop.
It really isn't. So, but what I wanted to say really is sort of two sort of issues that struck me. I think having a care plan is sensible. I think having to start that transition timeline much earlier sounds an extremely sensible idea. It gets that young person and their parents accustomed to the change that is inevitably going to come. And I think it's useful not only just in terms of learning and in terms of social care, but it's also really useful in terms of health interventions, because how many groups have we had before this committee? And one of the great issues of concern is that transition from children's care in terms of the medical world and adult having to move to adult services, which is a whole new world and much more difficult to navigate. So I think that it makes sense on such a range of levels. It's a long time since we actually heard about the department's review of learning disability services. Do you have anything, Alma, that'll bring us more up to date on that, or should we as a committee actually just ask for an update on where we are?
Yeah, I think it was supposed to come out maybe March, April time, and then it's kind of just floated away. So I haven't really heard anything. So it's probably a good question for you all to ask. What's happening? Because I have no idea.
What communication have you had with that review team?
Very little. Very little.
And you see, therein again is another problem. Mm-hmm. Another huge problem that we keep coming up against over and over again in this committee. So when you ask, for example, the Royal College of Emergency Medicine, what connection do they have to the safer staffing legislation that the minister's supposed to be bringing, they don't know anything about it. Mm-hmm. And you, who are so impacted by any review of learning disability services, have had very little communication in that respect.
I suppose there was, yeah, sorry Diane to interrupt, there was the road shows,
Yes, but nothing more specific.
But the road shows, you kind of didn't really get to ask what you wanted to ask, and it was, I'm not sure how useful they were really, but yeah.
Right, okay, so that's okay, we can follow that up as well. In terms of a care plan, why do you think it needs to be backed by legislation? I kind of know the answer to this, but I do think it's important to say it on the record.
Yeah, I think, it's, look at all the cuts, the voluntary sector and everyone else. If it's not underpinned by laws, it's not going to stay put. We need something to make that a really firm foundation. There's no point me saying put all that effort into this care plan, pull it all together, and then it just, like other, I hate to say model strategies that drive me crazy because that's all they are, it just falls away. It needs to be statutory. because we don't have any statutory
So
rights.
in other words, the important issue around the care plan is it's like a statement of educational need.
Absolutely.
It is a legal guarantee.
Yes, and it means that departments have to have responsibility. At the minute, nobody wants responsibility for post-19, unfortunately, and complex needs. Clearly, you know, the health minister has said he doesn't really want responsibility for it, but he needs to. So I think that's why, yeah.
Okay. Whether the minister wants responsibility or doesn't want responsibility for it, or wants to act on it or doesn't, it is his statutory responsibility. So that cannot be escaped. That said, I do think that we need a kind of more holistic, cross-departmental approach, which will encompass health, communities, education. It has got that all-encompassing approach, because that care plan might involve housing, which is a community's issue, you know, et cetera, et cetera. So I think in my head, it probably would need to be an executive-backed approach, but primarily the responsibility for this post-19 end of it is firmly on the shoulders of the health minister. Can I just say thank you for your presentations. As always, it's very thought-provoking. It doesn't matter whether that's a child who's 11 or a son who's 40-something, because all those worries, while they might be different at different times of that young person's life, they all amount up to the same thing, as to what services will we have, how will we cope, and if I'm not here, what will happen? And those are very, very pressing worries. And I'm absolutely clear that we do not do enough to address them. But we will persist, and I know that you will persist with the campaign. Thank you. Thank you.
Thanks, Chair, and thanks again for presenting to committee again. I had met with a large group of parents back at the end of last year in my local area, related to a special school. All parents who were facing that cliff edge to discuss transitions, and one thing that I walked away with was that the vast majority of those parents all had something very in common, and that was the vast majority of them had all required mental health intervention as a result of stress, and many of them were all on medication as a result of the stress and the fear for the future. And today, I think all of us in the committee here picked up very clearly that the four of you shared something in common, that all of you expressed emotion in here today, and it was very moving. And particularly Alfie, our hearts go out to you. I think you're an incredibly resilient, brave man, and we all take our hats off to you and to your team. I'm just wondering, in the back of that, Alma, as a result of your campaign, do you collate information from all those parents who are suffering and who require mental health intervention? Because there must be an epidemic.
Yeah, I mean,
amongst the people who are all facing that cliff edge and who are all undergoing huge stress that none of us really can appreciate.
Totally. I think my inbox is full every day of the week. You know, one of the things that always kind of gets me a little bit is we have an amazing community of parents, because it's parents that teach other parents where to go next. We all help each other because we have no choice. But the sad fact is the system doesn't help us, give us information. We have to find it out from each other. Communication is massively missed. You know I've talked about it before, the guidance from cradle to the grave. There's no timeline, there's no referral pathways, there's nothing that we are given to say this is what's coming next. So we're reliant on each other, and that's where the stress and the mental health kicks in, because it's so, imagine we live our lives on a cliff edge. We're on the edge of a cliff every day because you don't know what's coming next, the uncertainty, and then you get a phone call to say, by the way, you have to have this, by the way, your son's in their 40s, you know, one of them now has to have an OT assessment done. You know, no explanation, trying to understand, strangers coming into your home. You know, it's very, to me, it's so unnecessary. But I think, you know, a lot of the parents that come through, I am constantly, and there's only me on social media doing it myself, and you know, I'm having to try and help probably hundreds of families. You know, I'm doing this because I believe in it, but it makes me quite angry at times because I'm getting the full force of people's stories, and that's why I bring people to committees like yourselves, because really, this is real. This is our lives. Alfie is living this every day. He will go home from here and he will go right back into that caring role. And I think I would ask as a committee, you know, if there's a way that you could look at his situation and supporting them as a family. You know, I think that needs to happen. I think there needs to be pressure there. He should not have to fight. And I know his daughters are absolutely amazing. They're a lovely family, and it's just so wrong to me. And yes, mental health, no wonder we're all struggling.
Yeah. Could I just from conversations that I have with parents at my daughter's special needs school, which is Parkview Special School in Lisbon, that's where you really hear the disparity between who has a social worker and who doesn't, who gets direct payments, how many hours a week their child is allocated. The difference is phenomenal. And the PIP process, reapplying for PIP at aged 16 when it transfers from DLA, I know that's finances, it's not health, but all the input comes from health. You have to get a medical health practitioner to give input to those forms. And then there's a scoring process at the end of that form. Yeah. And so many parents, if that form isn't filled in correctly, the score from their previous DLA, when it transfers to PIP, can drop, and they can then lose their higher rate of mobility care. They could lose their wheelchair accessible vehicle if they don't score high enough on that form, which is ridiculous if you've already had that in place. So it's that kind of unnecessary stress that we just don't need. We just don't need. And yeah, when you're talking to someone and they're getting more direct payment hours than you, and you're thinking, but my child's more severe, why is that? They've been in the system longer. People coming to direct payments now, say, at Jacqueline's, the age of her child is probably severely disadvantaged than my daughter, who's been in the system from earlier on, because there's that withdrawal of the appropriate services.
Yeah, and sometimes when you bring up direct payments and you're having those conversations, then the parent comes along and goes, what's direct payments?
What's direct payments?
And then you start the whole conversation again.
Am I entitled to a social worker? Yes.
Yeah, and just in terms of the roadshows, we had raised things in the roadshow as well about data, and I had mentioned it earlier, and we were told, oh, the Compass program's coming in. And one of our parents said, well, my daughter's 19 and I actually can't get her on the Compass system because she's an adult. She has to sign up herself. So how do I get her on there? And the panel just looked at each other and they didn't know the answer to that. And one other thing that I've sort of realised as we've gone along this journey, that none of the departments that we're dealing with, for example, social services, come out and they're not, their forms and the things they do are not designed for disabled children. They're designed for children who are at risk. So you're treated, and the questions that you have to answer is as if you were, your child was at risk of harm. And also the OT, I tried to get help with a bath downstairs because my daughter floods the house and it was dangerous. The water was coming through the roof, and they said no, because she can physically walk up the stairs. Computer says no. And then they said you have to take your bath out up the stairs to get a bath downstairs. And I was like, so I have to just destroy my upstairs bathroom for no reason. It's just the systems don't seem to be designed. We're kind of slotted in everywhere. And I'm just wondering, is there a case to have a Minister for Disability that will pull all these things together from all of the departments and be that spokesperson and point out and deal with all of our concerns and find out where the things aren't geared towards our families and try to coordinate that?
It is just incredibly frustrating that people, human beings, at the most vulnerable time of their lives, have to fight tooth and nail for everything and anything. Just to pick up slightly on what Deanne had said about the communication with yourselves in the department, I know our most recent response that we got from the department in May last month, it did make reference to the draft learning disability model and talked about the involvement of people with lived experience, families, carers and providers. Did that stop at roadshows? That's it.
Probably. Jacqueline, did you? I don't.
Yeah,
Yeah.
but disappointing to hear that.
There was a roadshow. When was that? No, it's probably
Roadshow.
6 months ago. They said that they would have to take time to analyse all of the data from the roadshows. I have no idea why it takes that long.
I think during the roadshows we weren't really given much time to ask, and I don't know, they had, a panel on the stage, but yeah, I think you were restricted, I felt, in, what we were asking, so.
Terribly disappointing to hear. Thanks, Chair.
Thank you. No, that was powerful testimony. We really appreciate you coming and spending the time with us and sharing your experiences. I'm sure it was not easy, but it's been very informative and useful for us. So thank you very much.
Can I just ask you one question to go away and find out, because I'm very, very curious about this. Is it, if you, as committee, I don't know, maybe you know the answer. Who governs the trusts? So Mike Nesbitt is the health minister, and he is over the trust, but who actually governs them day to day?
Chief executive. There's a chief executive in each of the trusts. They're responsible for the work of the trust.
Right. Interesting. Thank you. I also have a checklist for each of you, which actually states, this was done by Denise Geary, one of our wonderful mums, and it is a 2-pager, and it tells you everything that we have to go through from the age of 18. So it'll give you an idea how, I don't know how parents navigate this without having mental health issues, but I'd like to leave you with those so you can see. Colin, maybe I'll just bounce. And thank you.
There's the chief executive of each trust. There's also a board and a chair, so
right, okay.
They are ultimately responsible.
Good to get that. Thank you.
Okay, thank you very much.
Thank you.
Thank you.
Thank you all very much.
Thank you.
Thank you,
Thank you very
Alfred.
much, Alfred.
Thank you.
Thank you.
So, members, just before we move on to the next item, so there's obviously an awful lot there. A couple of things just maybe want to separate, because Alma asked that we perhaps take Alfie's situation. I mean, are people content that we write to the Minister specifically in relation to we can find out details that we need to, but specifically on the scenario where the care has been removed from Alfie, and just get and add the committee support to all the rest of the situation and get an update in relation to that? Are people content with that? And then obviously there's the wider issue. So there's an awful lot of stuff. We have wrote to the Minister and the department a couple of times, and there's been a lot of to and fro, and the Minister has made his position clear. But accepting that this goes beyond the Minister of Health, but primarily a lot of it needs to be, in Alma's word, led by the Minister of Health, and she said she wanted everyone to put pressure on the Minister of Health to lead it. So, I mean, there'll be other things that members want to add to this, but I do believe that the Department for Health shouldn't be sitting on their hands for a year, even if the Minister can't bring forward or isn't bringing forward legislation here. There's preparatory work that can be done within the department so that after the next election, whoever comes in can hit the ground running on this, and that we're not wasting another year. So that's one thing that I think that we should be making clear to the department, that we want the department to begin preparatory work on this issue about a care plan and package from 19. So Orly and then Colin.
Yes, so just a few other things. I think that we need to, the point Diane raised around the learning disability, can't remember the SM, what's
so
the LDSM.
Sorry to cut that off. We can actually raise that in the next session and maybe get answers in relation to that. Mark McGuckian is that's a responsibility that we can ask him for, even though it's not technically what he's up for. So I'm not saying we don't include it in the letter, but we might get answers.
The other thing was around the data that Jacqueline was raising, so that there's no adult data, there's no data on adult send, and the issue around the data sharing between the DOH and the Department of Education, that seems obviously like a big issue, one that I'm not across, but I think if we can follow up on getting some clarification around that. And then the other thing was around, so see this English model, I don't know if the committee can request that we get some type of research paper drawn up to show how that model is, works in practice in England. It might give us a sense of even that issue around some of the costings of this. And if we can ask the Minister then in our letter to the Minister, has he given any consideration to other models of best practice or costed any of this up around that model, the Correct Assessment Plan that's been in place since 2014? Again, in the research paper, I don't know, Keith, if it's doable to ask if there's any similar models that are in practice in the south of Ireland and Scotland and Wales, just if there's whatever information could be gathered.
Elsewhere.
Yes. And then the final thing was around the issue around the benefits, because I think that is terrible that those families have to go through that process of reapplying for their kids and trying to prove the case that my child is as disabled now as they were. It's awful. So if the committee could maybe write off to the Department for Communities or the Communities Committee to maybe undertake a wee piece of work or engagement with the Minister and the Department around if any consideration can be given to speaking with the benefits offices to see if a conversation could be held with Alma and the team around, because modifications can be made. We done it with the mesh implant scandal, and we actually met with Mesh Ireland and the benefits offices, and they then took into consideration, right, well, we didn't factor that in, and they were able to change some guidance around doing those assessments.
I mean, we'll remember a couple of months ago where we had the issue of the private company from England coming over, carrying out assessments of people who, and that was, there are situations and scenarios where things don't change, and there needs to be taken account of that so that you're not harassing families and putting them under pressure. So totally agree with all of those points earlier. Okay, Colin, sorry.
Sorry, Chair. Oh, sorry.
Mine was just that we've got Mark McGuckian next, and we could ask him about the implementation of the model.
Okay, Dan.
Yeah, I think it's worthwhile asking Mark, although he may not automatically know because he hasn't come to talk about it. But I think the issue is broader. So it's a broad issue, not just about health or about education and social care or what happens post-19 in those areas. It's also a health issue. We had a very powerful talk from a young woman who developed arthritis when she was 2. And this was in Stormont a few weeks ago. Developed arthritis when she was 2. Very articulate young girl, is currently doing a higher degree apprenticeship with PwC, etc., etc. But she said that the most traumatic thing about her life so far was the transition from children's services and health to adult services and health. So does a health and care plan actually cover both health and social care and any post 19 education? And I just think that is a really important element of it. And I would be keen to find out, does the new learning disability model actually cover health and services in that respect, as well as it does social care as well?
And you're right about Mark. We can ask what we can ask, and if we can't answer, we will make sure that we get the information from him. Danny, did you want to come on that?
Yeah, just on the same point as earlier, just the barriers and asking just about the data sharing, any data sharing between education and health, if there are barriers in that, because that is something that can obviously be addressed. So.
Thank you, everybody. So we'll just literally just move on now to the next one, which is an oral briefing from the Department on respite services and short breaks. So page 65 of our main pack, and that includes a briefing from the families that took part in the Spotlight programme as well. So we'll just wait on our guests coming. Keith, you want to give me that water? Thirsty workers. So I'd like to welcome Dr. Ciara McKillop, Interim Director, Community Care within the SPPT, Mr. Mark McGuckin, Director of Disability and Older People within the Department, Ms. Maura Dargan, Director of Children's Services within the Northern Trust, and Dr. Tom Cassidy, Director of Children and Families within the Western Trust. So you're all very welcome. We've got some information in advance of the meeting, but I'm going to hand over to yourselves if you want to make some introductory remarks.
Yeah, I'm going to do that, Chair. Thank you. And thanks to the committee for this invitation to attend today's session to provide you all with a further update on services for children with disabilities. As you mentioned, Chair, we have sent you through a detailed written briefing paper in advance of the session, and the briefing details for you the range of work and the range of ongoing activity that has been taking place across the region within services for children with disabilities. We are aware that committee members have been particularly focused on the number of short break and residential beds commissioned and their current status, and we appreciate this very important issue, but we want to assure all members that we have also maintained a focus across the continuum of services that support children with disabilities and their families. The ministerial investment has enabled the trusts to develop and enhance a wide range of services which have all helped to provide invaluable support to an increasing number of children and families, recognising that all of these children have individual and complex needs. The initiatives across the Trust range from, but are not limited to, developing and expanding voluntary and community services and contracts, providing cash grants and vouchers for families, developing and expanding fostering short break services for children with disabilities across all of the trusts, developing and enhancing edge of care services which can wrap support around families at times of significant stress and need, expanding residential short breaks and residential care services, developing multidisciplinary teams including allied health professionals and specialist learning disability nurses, and developing strengths-based parent support programmes. We also need to consider that the range of developments detailed for members in the briefing paper has been completed during a time when workforce pressures continue to remain very challenging across our trusts and our community and voluntary sector colleagues. For example, vacancy rates in the Children with Disabilities community social work teams for band 5 to 7 qualified social workers were noted to be between 4.9 and 46.5% at the end of April 2026. One of our trusts has gone out through 4 recruitment cycles before being able to successfully fill vacancies, so we continue to face a very challenging backdrop. In regard to residential short breaks, whilst we very much welcome that there has been a reducing trend in the number of children on waiting lists for residential short breaks, I must be clear with the committee members that short break services for children with disabilities remain exceptionally fragile. The data collected at a regional level does indicate that the investment is beginning to address the key issues of concern and that the trajectory is going in the right direction. We welcome that alongside the positive feedback received from families regarding the impact that the support services have had, and some of this you will have seen outlined in your paper. However, the committee will be aware that a very significant medium to long-term residential care gap continues to exist across the region. There are currently 9 children residing in beds that were initially developed and opened for short break purposes, and as a direct result, this is a regional loss of 21 short break beds. So obviously it will be necessary to address the gap that exists in children with disability specialist residential provision alongside preventative community-based services in order to protect the availability of short breaks. Therefore, further sustained investment in both capital projects and workforce will be required for years into the future. And whilst we are clear that short break services for children with disabilities remain fragile, it is positive to note that as a result of the investment, there have been 787 additional overnight short breaks provided by the trusts in 25-26. The investment has also allowed trusts the opportunity to be creative in the provision of short breaks, and some have utilised short breaks from community and voluntary providers, including using short break stays in the Children's Hospice. We do acknowledge that there was some underspend against the original available funding of £13.1 million in 25-26, in the main linked to the workforce challenges that I detailed above. And in that context, significant efforts were made by the trusts to develop alternative proposals in the 25-26 year to maximise as far as possible the support to children with disabilities and their families from the available funding. We fully accept that there is much to be done, in particular in protecting and enhancing short break beds capacity. We want to assure the committee that we have been and we continue to develop and improve the continuum of services for children with disabilities across the trusts and the community and voluntary sector, and it is important that efforts so far do not go unrecognised. The message that we hope is received from this update is that whilst we acknowledge there is more to do, we also recognise that there has continued to be progress across all of the 5 trust areas. Thank you.
Thank you. I'm just going to dive straight in. So 13.1 million, how much of it was spent last year?
9.4 million.
And what happened to the underspend?
The Trust used as much as they can to enhance community and voluntary sector contracts, to purchase equipment, to use, to provide grants for families.
It was all used within...
I don't know if it was all used, Chair. I would need to come back to you with the full detail on that.
Okay. And how much is expected to be spent this year?
We're expecting 13.1 million to be spent this year.
So you said that there was 787 additional overnight stays last year, which is positive, but we lost 20 to 21 beds in long term, so when 3 units fully paused, so we're going up and down or staying the same. We're not making total progress.
No, we still can't. We have 787 additional beds, but at present, 787 additional nights, but at present we have the equivalent of 21 beds for short breaks out of the system because they have 9 children living in them, if that makes sense.
So I expect a lot of members will want to come in on this, so I'm just kind of firing quick questions here. So I mean, 13.1 million was additional money came about after the Spotlight programme, and I mean, as a committee we've obviously had quite a bit of engagement with the families involved in that. So that's 2 years ago, and as we sit here today, so 3 of the 5 families have had a solution, but 2 of the families 2 years on haven't had a solution.
Chair, I'm uncomfortable getting into discussions about individual children. And we can provide written information in regard to that, but I don't know that I would be comfortable, or that I would ask any of my colleagues to discuss the individual circumstances of any child.
Fair enough, and I mean, I'm not identifying any of the children, and I mean, we have specifically asked because to say this. I mean, this funding came about as a result of that programme. We all watched the programme. It struck a chord with anybody that watched it. To be honest with you, I mean, we've had Caleb's cause on before us. I mean, this is a very, very important issue, and I suppose why I'm asking that question is because you can't listen to these families, whether it's the families that we listened to just previously, or certainly that programme. I mean, it probably took me twice to watch that Spotlight programme because it was so emotional. Yeah. And yet 2 years on, 2 of those families haven't had their needs addressed. So I mean, I'm not asking you to identify the individual families, address the issue that why is that the case, given that there was an extra money put in place, that there's political support for this issue, and these are families who need something put in place, and yet 2 years on it hasn't happened. So I mean, if we could address that issue even more so than the individuals involved.
I suppose, Chair, it's important to note that the investment wasn't just for those 5 families. totally accept the point around watching that programme and the spotlight it put on this area. So it wasn't just about the additional respite, as Ciara says, about the whole continuum of care. It's about how we also address individuals coming through their life so they don't get into that crisis point where they need residential care. So the 13.1 million, and there was only something like 1.7, 1.8 million spent in 24-25. So 25-26 was the first year. I don't have the exact figure, Chair, but 25-26 was the first year we had access to the full 13.1 million, because we didn't start at the late in the year in 24-25. So I suppose it is, and the paper does set out exactly what that money has been spent on across a range of services. So it's not just purely about those 5 families. Those 5 families were the conduit and I suppose the catalyst that brought this to the fore. And as you say, very emotive. And the Minister did then prioritise that funding coming through on a recurrent basis. So the first year there was minimal money spent. I say 25-26 was the first year when they had access to the full 13.1 million, and as Ciara said, there were significant challenges there in terms of spending all of that money. And to be fair to Trust's Minister, or to be fair to Trust's Chair, they came forward with proposals which far outweighed the 13.1 million at the very initial stages of this, and we looked at those within the department and based upon a criteria said what do we believe was deliverable, and then went to the Minister for that additional money. So Trust did come forward with an awful lot more than that, but we looked at it in terms of what we believe was deliverable against the set criteria.
Yeah, and Mark, I accept that the money was for more than just 5 families, but I suppose, you know, I'm kind of asking about the progress and tracking within the department to deal with the needs of high risk families, which they certainly were. So, I mean, who is responsible, if anybody within the department, for identifying high risk families and prioritising their needs throughout the department?
It's not necessarily within the department. The Trust look at those families on the edge of care. And they will track those families through who are on the edge of care, who are, and maybe one of the colleagues would be able to explain this better than I can, Chair. But they do track those families on the edge of care, and they do provide support to those families. That they may not be getting the full respite provision that maybe those families would want and deserve, but there is a continuum of care the whole way through that. I think we, even the last time we were here, I think, Chair, we were talking about those families who hadn't had an allocated social worker, but they were still getting all of that support throughout that, while they were still waiting for a social worker. I think it was potentially Colm had said around there was maybe 30 or 40 incidents of support to an individual family, but they were still on the waiting list for a child social worker. So it's not that we lose any of the families that are on sort of heading towards that difficulty, but I don't know whether Tom or Maura wants any more about the edge of care.
Yeah, well, I suppose the Spotlight programme families aren't from the trust that I'm responsible for, so I'm not in a position to talk about them, but I'm aware, and the way we all operate is that we have assessed need of a range of children, and we try to meet that need as best we can from the lower end through to the upper end, and we identify families who are struggling more than others, and we respond in a greater way to those families as we try, but we are dealing with limited resource, and that's where the challenge comes, because you're talking about prioritisation all of the time and the juggling of the available resources that you have to meet the majority of the need the majority of the time. And as we have discussed before, and as committee is fully aware, that as families struggle to a point where a young person needs to come in to the care of a trust, either on a permanent basis or a long-term basis, then that can block the facilities to provide the short breaks. So that's the ongoing juggling that goes on. But each of the units that provide the level of short breaks to families are in regular contact with families and regularly updated in respect of the pressures and stresses that are happening on an ongoing basis, and there is a continual prioritisation as that happens. So that's broadly how the mechanics of it. But yeah.
So it would be the same in the Western Trust, in the sense that as director I would be aware the families that are under severe stress. And if you look at some of the documentation, I mean, some of the things that we've done to support families, for instance, like the specialist support service, and I mean, that's dealing with very, very complex families who are, in need. And there are a number of situations where we've actually been able to intervene to stop young people coming into the care system, to support the families to allow to do it. But we recognise that residential short breaks is a major component of supporting families, and we are striving to do it. We've been able to begin our residential short breaks just last weekend. We've managed to accommodate young people in one of our homes in Rosewood for short breaks. But the difficulty with that is that it's a fairly fragile service, in the sense that if we do get one of those complex families that need to be looked after, then that can block it. But we're working tirelessly to try and support these families.
And just in terms of oversight from the centre, I mean, Mark and I co-chair the oversight board for the use of this investment, and we meet the trusts on a monthly basis, and we go through progress or deterioration on a line-by-line basis. So
some of these families that were highlighted in the Spotlight programme raised similar issues 10 years ago, and they're raising similar issues today. So, and then some of them still 2 years on haven't had the package that they need to be able to support their children. And it's just, respite is so vitally important. I mean, we've heard, and they're back on again, from our previous presentation, just how much respite is, how vital it is for families who are struggling and for their own health and well-being need this. So that's why I'm kind of being a bit emotive in this. I just want to know that, because one of the families that hasn't had a solution yet, their child is going to be there's a potential to get a solution at the end of June if everything goes okay, but then their child is 18 in November and they've no idea what's going to happen there. So I mean, I kind of trying to know, is there policy changes within the department that are taking on board all of this? I mean, if this was reflected 10 years ago and we're still having these conversations, I kind of want to know what lessons the department is have learned to help and assist families through all of this respite process, but also given the previous conversation at 18 or 19 that they're not dealing with bureaucracy and they don't know what's going to happen to their children or young people when they reach a certain age.
Chair, I suppose we've updated before on the new approach to the Learning Disability Service model, and we have consulted on that. We have paused work somewhat on the Learning Disability Service model because we want to see the recommendations coming out of the Muckamore inquiry, which is publishing next week. So we're looking at the consultation responses that have come in from memory. Over 250 consultation responses come in on that. So that would be our new approach to it. And the Learning Disability Service model looks at the journey throughout. From early childhood right through to adulthood and then in the old age as well. So we are trying to change the system that you're not at a cliff edge at 18 or 19 and through into adult service and then through into older people services. So and obviously resources will be an issue in terms of implementing the Learning Disability Service model, but we're also looking at what we're currently spending and trying to change a lot of it from day opportunities or day care into day opportunities and trying to rebalance exactly what we're doing. I agree with you. The respite is still an essential part, and I think, I'm not sure if it's in the papers you got, Chair, but from April 25, those on the waiting list for residential short breaks were sitting at 332, and April 26 is sitting at 173. Now that's still 173 too many sitting waiting on that waiting list, but we have done significant in terms of bringing that down, and Ciara's mentioned in terms of the additional nights. As Tom and Maura have mentioned, it is a fragile service, so you get one family in crisis who we need to put in for maybe longer than a short break, and that does then collapse the service to a certain degree until we can get those families in a position where either their child can go home or their loved one can go home, or we move them into some other setting. So it is, I don't underestimate the amount of work that's being done at Trust to try and resolve this, but I agree with you, we need to do more. Say 173 people waiting is still too many waiting, but hopefully in terms of your question around what are we doing differently, what lessons have we learned, the new model and the new approach will hopefully address a lot of these issues. It will take time to embed that, it will take time to make sure all trusts are doing something in the same way and in a uniformed way, but that is the department's way forward on it.
One of the things, Chair, that we tested with the money this year was about the transitional arrangements between our children's short break units and future care arrangements on a long-term basis at adulthood, and we use some of the investment to allow the transfer of 2 young people into a long-term adult facility prior to their 18th birthday, so they would have been 17 and a half, and the funding allowed us to do that. But that was something that had never been done before and required the engagement of departmental colleagues alongside RQIA, but we managed to unlock some of the historical challenges that would have been created in respect of that, and that has been very successful. So we now have another young person who is due to turn 18 in November, and we're already working with our voluntary colleagues to look at a suitable property and begin to see, can we move on some of these young people earlier into their forever home, which then maintains the fragility, I suppose, of our short break provision. So there are some things that we're trying to do to unlock hurdles previously kind of in our way, but it's around the edges.
So, I mean, there'll be a lot of interest in this. So, just last quick question for me. So, Nigel Chambers used to lead within the department. He's moved on. Has he been replaced? Who's replaced him?
He hasn't been. Nigel sat within my team, Chair, so he hasn't been replaced at this stage. We're looking in terms of even internal resources within the department. That's very challenging at the minute, given that we're trying to make cuts within the department and within Trust. So his post has not been replaced at this stage. Part of the adult LD side of Nigel's work has been transferred over to one of the guys who's looking after the Muckamore end of things, because there's synergies between what's happening in Muckamore and the wider LD stuff. The children with disabilities and the autism is being handled on a temporary promotion at this stage, but there's been no formal replacement for Nigel. Doesn't mean to say the work hasn't continued on. I say the work around the learned disability service model and the consultation responses has continued on in Nigel's absence, but the formal post has not been replaced at this stage.
Nola?
Thank you, Chair. Sorry I'm not there in person. I was at the policing board and then meeting with residents in North Belfast following the disorder this week. I had wanted to be there in person because this is quite a significant issue and I have a number of questions. First up, I want to touch on the Northern Ireland Children's Hospice. In your opening, was it Ciara that?
It was me, yeah. It was.
Yeah. You had mentioned with regards to working with the Northern Ireland Children's Hospice on respite beds, but that's not my nor the committee's understanding. Our understanding that there was no additional respite beds, the 13.1 million given to the Children's Hospice despite a request. So I wonder if you could just go over what it was that you had said.
Yeah, I will go over. I mean, the committee will understand that the Children's Hospice is the sole provider of children's hospice and palliative care services in Northern Ireland, and it delivers inpatient hospice care, planned and emergency short breaks, end-of-life care, hospice at home services and family and bereavement support for children with life-limiting and life-threatening conditions. So the hospice would be suitable for some of the children with disabilities and it will not be suitable for others. In terms of the funding arrangements, we currently provide £1.61 million of recurrent statutory funding to the hospice. We provided an additional £500,000. Minister made an announcement in May to meet an immediate financial gap. This funding was non-recurrent, and we are working with the hospice to look at a sustainable model of funding and service delivery going forward. What we commissioned provides 1,500 short break bed nights and 310 palliative and life-limited care bed nights annually. And the hospice supports 250 children and families each year. And that's, I suppose, the central contract. And then some of the trusts also spot purchase or have individual arrangements with the Children's Hospice. So I don't know if Tom wants to...
Well, the West we have utilised the Northern Ireland Children's Hospice. Between January 25 and March 26, we with 93 overnights for 3 young people. Because as Ciara said, you need to assess just the suitability of that. And then we've also realigned some of our contracts to purchase another 46 overnights at the Northern Ireland Hospice this coming year. But they are spot purchases in that context. So you're right, Nuala, in that sense. It's not.
Yeah. So why not? My understanding is that in December 2025, a business case was submitted by the Children's Hospice for a 7th bed, which would be a permanent. Now, whilst that business case may not be directly attributable to the 13.1 million, that 13.1 million is recurrent. We have seen it, it's been an underspend. Why was no money given to the Children's Hospice from the department and instead all allocated to trusts? We had the hospice up last week or the week before, can't remember the time, and they informed us that whenever there's money or there are beds given by the trust to the Northern Ireland Children's Hospice, that the funding that was offered that way for respite wasn't actually covering the entire service that would need to be provided for the Children's Hospice. But now you're telling us that there was an underspend for the 13.1 million, and we had an organisation that had their hands up, jumping up and down, literally saying we can offer overnight respite, and they were told no. Why?
I suppose 2 answers. One is that we did provide additional funding to the hospice last year, and as you've indicated, we are currently working with them around
in the 13.1 million.
Well, I mean, I suppose Tom has said, and I've said, we aren't able. Not all of the children with disability services are able to use the hospice for short breaks, and we did provide them with additional funding last year.
But not out of the 13.1 million, and there are of the 173 previous 332 families waiting for respite provision. There were a number of those who would have had complex needs that could be met by the Northern Ireland Children's Hospice, and they were still told no, despite submitting a business case in December 2025 for an additional 7th bed, which would be permanent.
We are working through that business case with them at the minute.
But why was the money given to the trust and no money given to a provider who could offer respite, and why was there then an underspend?
Because we, at the time, Nuala, we asked the trusts for proposals in terms of meeting the need. So the trust came forward to us with a range of proposals. I already said to the chair at the start, the trust came forward with significantly more proposals than we allowed them funding for. We assessed them and we looked at what we believed was deliverable. We've already noted that there are significant challenges in terms of staffing and recruitment, which is largely where the underspends came from. Trust did as much as they possibly could to spend any underspend that was there. We allowed them to come back time and time again for reprofiling the underspend, and I believe trusts were doing as much as they possibly could to spend that, Nuala. But we honestly we didn't go out. If we had have put an open call out, we couldn't have just went to the hospice to say we will fund you. We would have.
Why didn't you do an open call, given it's something that's in such crisis? Because there's not a large number of organisations out there, Mark, that can actually offer respite. So why wasn't there an open call?
Well, there's a significant amount of community and voluntary organisations who do provide support to the trusts, Nuala. So there are other organisations. In terms of why we chose to do it through the trusts, there are service delivery organisations on the ground. So we delivered it through the trust because that was the most efficient and the quickest way to get the money on the ground, to be perfectly frank, to get it out there, rather than going out to an open call and going through procurement and contract arrangements to do that. So that was the decision that was taken by the department to put it through the trusts.
Except the money didn't go out under the ground because it was an underspend of 13.1 million and it wasn't all spent. Was there any point then when the trust came back and the initial proposals that they came with and you said, no, that's too much and won't be able to deliver that you were able to say, okay, then let's add these on now because you could perhaps deliver that now, you know, given that we haven't been able to spend all of the 13.1 million?
There was backwards and forwards at the initial stage, Nuala, when the applications come in or when the proposals come in. There's been backwards and forwards throughout the year in terms of reprofiling underspend and allowing the trust to reprofile that underspend. It's not that we said on the 1st of April, here's the projects you're doing and we will allow you to do that. There has been an ongoing process with new business cases coming in and proposals coming in from the trust throughout the year to reprofile the spend and try and mop up some of that underspend.
And see, when the money then goes out to the community and voluntary sector that are aligned with the trusts, so it's almost like so you give the money to the trust give the money to the community voluntary sector. They provide the money in its entirety to the community and voluntary sector so that they're not undercut, or they don't have to use any of their own core funding to actually provide the respite service?
The trust will go to this, and maybe Tom or more will be better to answer. The trust will go to the community and voluntary sector to say, here is a need, can you meet that need, and what will you charge us to meet that need? So there'll be ongoing conversations between the trusts and those providers who are providing that. I'm not directly involved in any of that, Nuala, but that's my understanding of how the process would work. So it's not that we would say we will only give you 50% of what you want. They will go out and say how much the trust will go out and say how much does it cost to deliver this service, and that's how the contract arrangement would work.
Okay, but I can maybe come back to that another day in writing, because it is interesting given that we had evidence at this session or at this committee in which an organisation told us that what they were being offered by the trust was not the entirety of what it cost to actually offer the service. And it'd be interesting to see if that's actually happening to other organisations. Going to move on to asking a question with regards to the Northern Trust, which I believe has Rainbow Lodge, formerly Rainbow Lodge. It has a new name. I can't recall.
Eden View.
Yes. Is there a standard trust policy to allow access for parents into Eden View? Or are parents prohibited from entering?
No policy that would say one way or the other. I wouldn't.
Oh, okay. And can parents enter Rainbow Lodge?
Of course, yeah.
Yeah, okay, of course. In the Western Trust, are there other providers in the Western Trust that allow parents to enter, whether it's long-term or short break respite? Because I'm not sure what your long-term residential placement is, and I understand is Eden View long-term?
Eden View offers both, Nuala, so it offers long-term and short breaks, but it hasn't been providing short breaks for a good few years.
Yeah, okay. I assumed that, but I just didn't want to be wrong. And with regards to Western Trust, are there any premises in which people are placed in long-term residential, children with complex needs and their parents can enter?
Yeah, my understanding is we have 3 short breaks that are in relation to, we've got Avalon, Rosebud, and my understanding is that there's no, well, I certainly haven't heard of any issue where parents have...
Well, I'm not sure if you're aware, but in the Belfast Trust, they have said that the general policy is, and it's not normal that they would allow parents to have access to long-term residential care homes into their children, where their children are now living. And they have said that this is a standard policy. But I'm hearing here, Mark and Ciara, from the Western and Northern Trust, and you know what I'm referring to, that they do allow parents access.
I think
what's going on there?
I think we're maybe using a number of definitions of the term access. Contact between children and parents and families is generally not offered in a children's home, but that is not the same thing as saying parents can't access a building or can't come in and out of a building.
Okay. Was it true that there was a birthday party held in one of the Northern Trust's long-term residential care providers in which the family were allowed contact in because it was a young child's birthday? Because that doesn't seem like it would be just access, that could potentially be contact.
Nuala, I honestly wouldn't know. I would have to come back to you.
Do you allow contact with parents inside the children's home at Rainbow Lodge?
Like Tom, I haven't heard to the contrary.
Okay.
I suppose, Nuala, what we did say when we met earlier in the week is that this is done on the assessment of each child's individual needs and the circumstances of that child and potentially other children within that setting. So, we did say that, and I know exactly what you're referring to, and we were very clear earlier in the week that is based on an assessment of the impact on that individual child, on any individual child, and the impact of other children within that particular setting.
That's not the only thing that was said.
I didn't say it was the only thing I said, Nuala, sorry, I said it was clearly said at the meeting earlier in the week.
And with regards to trust, I know that there has been a number of legal cases in all of the trust areas regarding care proceedings. And I just want to know that is it policy in the Western or Northern Trust that when relationships break down between parents and children with complex needs who are placed in a long-term residential facility, whether the next step is to issue care proceedings against that parent? Is this something that has been done on a number of occasions in the Northern Trust or Western Trust that you're aware of?
Not that I'm aware of in the Western Trust, but as Mark said, when young people are in the care system, there's an assessment made of each young person. So it is dependent on the individual circumstances. I do know over my career there have been times where we have said, the engagement with a parent is not conducive to the well-being of a child. But normally, in normal circumstances, that you work with a parent to try and ensure that contact is established.
Absolutely.
Because generally speaking, what you want is for a young person who is looked after to maintain contact with their family and their communities of origin, because research would show you that eventually when they move out, they go back to their community and their family of origin. So it may be slightly different, Nuala, for families with those very complex needs and health needs, and I'm not au fait with the case that you're referring to, but I would suggest that every case is done on an assessment basis, and there may well be occasions where you would take a care order. But if you do take a care order, you share parental responsibility. You don't.
But whose rights trump? At the end of the day, if you take a care order to get shared parental responsibility, if the trust and the parent disagrees, whose decision trumps?
I suppose that's
in your experience.
That's why the matter is placed before the court, Nuala, so that the court can make a determination about what is contained within any child's care plan. And their care plan covers everything in terms of where they live, what their contact looks like, education, future planning arrangements. And every decision to make an application for care orders is a completely individual decision in respect of that child.
Who would normally make that decision? Is it one person or a number of different people involved? Who finally decides that that's what needs to be done?
I don't understand what you mean. In the trust, who makes the decision that you need to make an application for a care order?
Yeah.
It's probably done on a multidisciplinary interagency basis. Now I don't know the individual case or whatever, but if you could have. And this example probably doesn't refer to children with complex needs and support issues and stuff. But if you're engaged in, say, a child protection process with a family, you would develop on a multidisciplinary interagency basis a child protection plan, which would be shared with and negotiated with the family. Now, if that child protection plan was not being adhered to, and there was felt that the child was suffering harm or significant harm, then that may well be a decision to first of all go to pre-proceedings. So you allow the parent to have a solicitor parent there, and you're explaining the situation to them. What needs to change for us to stop going to court. Now I'm generalising here, and then that would be on a multidisciplinary basis, and then you would put your case to the court. And the family, if they were not agreeing with it, they would put their case to the court, and it would be the court that would decide. But I'm probably not answering your question.
There will be legal. The child is independently legally represented in the court as well. So the court will appoint a court guardian, children's court guardian,
Yeah.
and the guardian will in turn appoint independent experts if they feel that the care plan for that child.
But what happens in the
needs to be
interim
looked at.
whenever you can't do that? Whenever you know that this takes so long, what happens in the interim? Do the trust usually apply for an interim order so that they can have their plan in place while it takes 6 months?
When you make an application for a care order, whenever it gets before the court, they can make a determination either that they give an interim care order or that the case proceeds on a no order basis, and there are negotiations about what the care plan looks like.
And at the minute, the guardian ad litem's are thin on the ground. So what happens? Sorry, Philemon, I'll ask just the last two questions here. At what point, if a guardian ad litem can't be appointed and it's appointed further on down the track and therefore it's not the independent voice for the young person, what does the trust do then?
Well, ordinarily the judge can be asked to make a determination pending a guardian ad litem being appointed.
Okay. Yeah, and then I just have a final question on that. 13.1 million for respite. Has there been any decision to reprofile that from resource to capital?
Just, again, to be clear, Nuala, it's not 13.1 million for respite solely. It's 13.1 million for that continuum of care. Okay, so at this stage, there has been no decision taken to reprofile in 26-27, nor have we been requested in 26-27 to reprofile anything from where it currently sits into capital.
No, I understand. Sorry, it's not just for respite, but the minister stood up and said that as much of it would be used for respite as possible, and I think that's what everybody, not just the spotlight mums, expected, that much more would be used for respite. And given there's only set 173, many people would think that you have used it, but actually, how many of that one of the gap in between the 332 and 173 have actually just aged out rather than waiting? I mean, it would be good if you could come back with us as to why the numbers in the waiting list have gone down. What are the reasons for it? Because people have aged out, or the trusts have actually carried out the role in providing the assistance needed?
Well, I think the paper of the committee details quite extensively what trusts have done in terms of the support they've been given to families. So I can only assume that a lot of those families who were on the waiting list have now been provided with that support. But if the figures are available in terms of those who have aged out, we will certainly provide that to the committee. I'm not sure, Chair, to be honest, whether those figures will be readily available, but we will ask the question.
Nuala, can I say that we were able to use some funding to purchase a building, which is only for one placement, one long-term placement. It's not yet available, and it's subject to ongoing revenue, business case resubmission, etc., and recruitment processes. But we would be planning and hoping for the last quarter of this year to add an additional medium to long-term bed in the Northern Trust, so that will bring us up to 6, and that we hope will protect the fragility, I suppose, of short breaks. So yes, we were able to use some funding for a capital purchase.
Okay, thank you.
Okay, thanks, Dan.
Thank you. So just a couple of questions from me. In your submission, you indicate that there are around, sorry, I've gone out of the page I wanted to be in. There are 865 unallocated cases in August 25 and in November 25. So from August to November, you have a reduction of 178. So in about 8 weeks, you're able to bring that down by 200 cases. And I know what Nuala was asking you about this, but can you be very specific as to how those 200 cases were reduced? Is there any way we can be more specific about that?
We probably need to go back to the trusts for the specifics about that.
Okay, because we need to know, all of a sudden, did these cases get a social worker? Did they get a resolution? Did they age out, as Nuala said, of children's services? What happened to them? The children haven't gone away, but what happened to their cases, because that's quite a reduction in 2 months. Okay.
So, Diane, sorry, in Northern Trust,
Yeah.
just as an example, our vacancy levels remained the same, but our sickness absence improved, and that therefore led to an improvement in our unallocated cases, just as an example.
Yeah, well, no, and there may be like perfectly reasonable explanations for it, but it just seems to me when you're looking at the data that is an unusual reduction in a relatively short period of time. When I look at in August 25, there was between an 8% and a 44% vacancy rates in the different bands. And for some reason or other, by November 2025, that vacancy rate had increased from 14% to 61.4%, yet you had a reduction in all unallocated cases.
Sorry, just to explain, the range that's given there is the range in vacancies across the trusts.
Yeah.
So
I get that.
Right. Okay. So
what I'm really saying is these are very broad brush numbers, which actually mean very little because we have no detail around them. And we really do need to know the answers around the detail around them. And I'll tell you the reason I'm asking. The reason I'm asking is I believe that there are loads of children out there on the edge of care. I was at a primary school in my constituency, and I spoke to the head teacher, and she said to me, Dan, we've been a bit of a fuss, and I ended up having to take home a child in a temporary foster placement because there was nowhere else for them to go. That's a terrible indictment on the system. It's a wonderful example of a teacher going over and above and beyond, and it makes me very humble that there are people in this world who do that, added to all of their responsibilities. But it tells me that these figures, which says we have unallocated cases, hundreds and hundreds of them, and yet I know like that's the case, that's only in the last 2 weeks. So, we are broken in this sense, and we cannot have children. Clearly, this child, I don't know the background and I didn't ask, but this child was deemed at risk or wouldn't have to go into an emergency placement. And that's
Give you a bit more detail, Diane, but not as much detail as probably we'll try to come back on. So those vacancy rates go across from bands 5 to band 7 across the various social work teams across the trusts. And you're right, it varies from 14.1% to 61.4 at November. At April 2026, the rates are sitting at 4.9 to 46.5, and unallocated cases in November 25 are sitting at 687 and down to 557 by April 26. So we will come back on the detail if we have further granular detail around exactly where the vacancies are at what bands and what's impacting them. I suppose in terms of short break foster, we have launched, I think it was last week or the week before, a regional programme across all 5 trusts, which again has been funded through this 13.1 million to try and actually increase the amount of short breaks fostering for children with disabilities across the 5 trusts, to have a consistent programme across the 5 trusts to try and promote that more widely. So I agree with you, when a teacher is taking a child home in those circumstances, on top of everything that else is doing, it does show a huge amount of commitment from that teacher. But we are trying to do that across the trust on a consistent basis now, and try and sort of increase the profile and the take up of short breaks fostering, because you're right, it makes a huge difference to those individual children.
So just, I've loads of questions, but maybe I'll just finish on this one question because it's also very, very important to me. There's people will know exactly what I'm talking about. So what is the length of time, the average, so what is the longest period of time that a young person who has been taken into care with a complex learning disability this young person has, to wait for that forever home and distinct placement? Do we have any sense of across the trusts the length of time that young people are waiting. I know of one young person who has waited 7 years.
Certainly, we.
So that is an awful long time to be institutionalised.
We don't have that detail with us today, Diane. I think we'd have to go away and look at those details in terms of delayed discharge statistics for young people waiting a forever home, as you say. And we're happy to come back to the committee on that. Sorry, we don't have that detail with us today, Diana. Apologies.
I think that is really important, because I think that is the nub of this issue. It's not the issue with every young person that requires a respite break, but there are some young people with complex needs who have either been waiting at home, as in the Spotlight programme young people, or have been waiting in care, but have not the appropriate care and have not the appropriate pathway for their future. And we are spending far, far too long, years in some cases, trying to find these young people a home. And it's not, those who know the case will know exactly what I'm talking about, but it's not something I will give up on, because I think it is immoral in this society that we have young people with very, very complex needs who are currently in care but have no pathway to an appropriate placement in the community and a home that they know will be theirs for a long time to come.
We'll have to come back to you, Diane, with those exact figures, so apologies.
Thank you.
Thank you, Dan. Danny?
Thank you, Chair. I have a couple of different questions in a couple of different areas, but I wanted to pick up on something. I think it was yourself, Ciara, had said that contact and access are two different things. Are there any residential long-term care facilities for children where parents are not allowed in the building at all? I'm not talking about parents and children where there are safeguarding issues.
It's really difficult to answer, because that will be individualised to each child and each parent and each unit. Danny, do you know, it's one of those things where you can't make a blanket rule that, you know, there can't ever be parents in or there can't always be parents in, because you need to understand the needs of the children who live there, because that is their home, and you need to be able to balance the impact of a parent coming into that unit on their own child and all the other children. So it's not a question that you can just give a yes or no answer to. It's completely, the needs of these children are so complex, as we have all heard, that each of their placements is completely individually thought through, and they will have completely individual arrangements that work for them and their carers and their family in terms of their contact with their family. So it is really not possible to give you a blanket yes or blanket no. It's completely individualised. Each child has an individual care plan, and that's how their care is organised by the trust and signed up to by their families.
Thank you. I think we all would be quite aware of the level of complex needs of these children. You know, we've seen the documentary, we've met with the families quite a few times now, and certainly I don't think this issue would be in the spotlight as much as it is if it wasn't for, you know, that documentary. Yeah. Certainly wouldn't have had the funding attached to it, and it wouldn't have had the announcements that we've had. I just wanted to ask you about the underspend. Now, initially the 13.1 million, about a quarter of it wasn't spent last year. Mm-hmm. The first tranche of funding that came in, I think it was November 2024, there was 2 million that became available. Was there an underspend then as well?
Approximately 1.4 million was spent in the first year, so there's around an 800,000 underspend from the figures I have, Danny, in that first year. But again, we brought this to the trust very late on within the year, to be fair, and the assessment that we did was that what was deliverable within that year, which is why we went for about the 1.8 million. I reiterate what I've said. I believe trusts have done as much as they possibly could to spend every penny they possibly could as well. We continue to move backwards and forwards and allow trusts. It wasn't that we give Northern Trust or Western Trust a pot of money, and if they didn't spend that was just lost. If Western Trust or Northern Trust weren't able to do it through the Oversight Board, as Ciara's mentioned, that was reprofiled across trusts as well. So it wasn't just we rigidly stuck. If one trust can't spend it, it doesn't go anywhere else. So I genuinely believe the trust did as much as they could, starting from a standing start, largely to get as much of that spent as they possibly could.
And I suppose, Danny, if I could come in, do you know, a large chunk of this expenditure is on staff. either healthcare professionals or the social care workforce. And I mean, I've been here before to talk about the challenges in recruitment and retention in both of those professional groups and in the trusts and in the community and voluntary sector as well. So, that's the challenging context that we're working against.
Certainly, one of the things you mentioned when it comes to vacancy rates, there was one of the trusts was 46.5% vacancy rates, and it was mentioned that there was 4 rounds of recruitment done within that social work team.
It wasn't. It was a different trust. It was a different trust, yeah. But they went through 4 separate recruitment cycles before they were able to fill posts. So I mean, I'm sure Maura and Tom can talk about recruitment challenges. But it's a challenge across professions and within the social care workforce as well.
Yeah. And I think we have discussed probably at length before about the challenges around social work, and the vacancy levels have been described. The other area for us is around our workforce to support our units, our short-term, our short break units and our longer-term units. So we have been struggling to open Eden View, the short break side of Eden View, for example, as a result of recruitment challenges. So we have been on quite a few cycles of recruitment to try and, I suppose, to get the workforce required to open beds in that unit. We are still challenged there. We have set aside another quarter, if you like, to try to move things forward in respect of that so that we can start to build short breaks back in Eden View. But it's a real challenge, Danny, to try to get interest in working in these very challenging and difficult areas.
Oh, I do appreciate that. My concern is for the repeated underspend, and what provisions are you putting in place now to make sure, I know you've said that, I'm sure there's business cases out for this year. What are you doing this year to make sure that all of that is spent in providing as many short breaks as possible?
I suppose that's the ongoing discussion that we have with the trusts at the Oversight Board each month. The trusts have a trajectory for getting the money spent in year. We each month are literally going through that line by line to see, are you on your trajectory? Are you missing it? What alternatives can we put on the table?
As an alternative, I think you mentioned the Northern Ireland Hospice was the only facility.
It's the only children's hospice we have in the region.
It's the only one that's contracted to do short breaks for children with disabilities, is that correct?
No, it's the only one that does sort of children who have life-limiting or life-threatening conditions. It's the only facility that they can use. So it'll be suitable for some of these kids, but it wouldn't be suitable for all of the kids, because of the...
Will that be kept as an available opportunity then, if there is... If you can see that there is going to be overspend in some of the trust areas?
We are in an ongoing dialogue with the children's hospice. We meet with them regularly. We understand the funding position they find themselves in. We did give them additional funding last year, and we're working through a business case with them for the 7th bed, and also to see if we're just seeing how we can support them, given that they're a unique service.
And I suppose, Danny,
there's 4 beds that remain closed at the minute.
Yeah.
So the capacity is there within the children's hospice.
Yeah.
Yeah.
We know that.
I suppose it's challenging as well, Danny, because we have to look at the impact as well on families travelling significant distances to the children's hospice. So we would prefer to try and do something which is more localised to the families. So a lot of the respite time isn't being spent travelling backwards and forwards to the hospital. I totally get, as Ciara said, that for some of those life-limiting children, that is largely the only respite provision there is, which is suitable. But we would prefer to work with more localised providers where they are available to provide those short breaks, so to say families aren't travelling significant periods of time as part of that respite provision as well. So, but as Ciara said, we continue to talk to the hospice on that business case they put in.
Well, I hope so now that can be used, and we don't have an overspend again. Underspend, sorry. Just one last question. Just the age of care families, I noticed had gone up by 2. Yeah. I know we are investing in early intervention, and we were doing vouchers and day outs and things. Why is the age of care, the number of age of care families that we're aware of, why is that going up?
It's just need is rising.
Despite all the early interventions, despite the money that's being spent. So need is continuing.
The level of need that we are.
Dan, I think we're on a journey with it, aren't we? Because a lot of the money and investment is just landing and being developed and being created. And for some families, it's arrived too late in their journey. And I think that is what has happened. I think as services get embedded and we're able to deliver to more, we can stabilise this. But I think we're just very early from spending money, getting an allocation, spending money, and actually working with families in a meaningful way to make a difference where they genuinely feel a support at the level that they are at. There will be time needed for that to embed.
Just with that, to add on to that, I think Nuala had asked how many children had aged out of the service and that we can try and work on. Can we also try and look at how many children then will have maybe, families will have been pushed into residential services, and that would have dropped the numbers as well? Would you have those numbers?
Yeah, we know of all our admissions. You know, the admissions are small, Danny. Yeah. So yes, we can provide that if
because obviously those families would have waited for, you know, increasingly long periods of time and then had to effectively look at residential services.
And I know in the Northern Trust that happened for us. It came too late.
I think that's where we're saying around that this isn't focused solely on respite, because we are trying now to address those families where maybe this did come too late. So those families who are either on the edge of care or within the system, we're trying to say, what can we do to support you so it doesn't get to that crisis point? What can we do to support you in terms of respite? What can we do to support you in terms of other activities, so that we don't get to that edge of care and tipping over the edge of care into needing residential. So as Mary said, you know, we are relatively short time into this, just over a year and a half. So we will take time to see this work its way through. And those edge of care figures, Danny, I think they could go up and down on any given day depending on the circumstances those families find themselves in. So it is just around trying, as you say, trying to make sure that we put as much support around those families at an earlier stage, and that's why we're trying to do it as much as we can across the whole continuum of care for these families and these children.
Thank you. Thank you, Chair.
Thank you. Thank you all. Thank you. That's been useful.
No, it's all right. No, it's okay. Conscious time.
Okay. Thanks very much.
Thank you.
Thank you.
Thank you.
Chair, could I ask a supplementary just quick, or?
No, I've dismissed everybody. No, I'm sorry.
Thank you.
Thank you. Thanks, guys.
Okay, members, Nuala, if there's something you want to raise now that we can write to them about, or anything else out of it?
Yeah, I mean, it was a supplementary. I just had one of the Spotlight mums off the phone. And it seems like the Trust are possibly backtracking on Redwood at the end of June.
Okay.
And I'm really concerned, and I am assuming it's the same person that Diane had spoken to. And from what I'm hearing, it's really distressing that they are supposed to have this place ready at the end of June, and they might not possibly have it ready despite having months upon months agreement that it would be ready. I have to wait to get the whole details, but I said I would ask, is Redwood ready for the end of June? That's the only question they wanted to know.
Yeah.
Is Redwood ready for the end of June?
In the departments, they said June, I think, subject to sign off or whatever.
Yes,
I can't remember.
there is something going on here.
Right.
And there's another quite serious issue in which they're now also issuing care proceedings against a family whose young person has complex needs. And we know that the trusts have not won all of the care proceedings that they have lodged with the court before. And I think that things from the department and the trusts are saying are getting better, but actually we are speaking with really distressed parents that things are not getting better at all. And they hide behind, we cannot talk about individual cases. They say to us in private meetings that this is a policy decision. But yet we hear when they come to committee that it's not a policy decision, that it has to be taken on a case-by-case basis. And there's still a lot here that I think that there's concerns that this all is not okay at all. And I think it will require a further update. I'm wondering if we can just ask them, the trust, for what their policies are in terms of having contact within, for example, residential children's homes where they are children with complex needs.
Yeah, I mean, I don't see any reason why we can't write to the department and ask that question. I also think we should ask the question about Redwood as well, so we can just write that and ask that for an update on Redwood. Okay, is everybody content with that?
There are a couple of questions, Chair. I was going to ask, maybe if you had asked the Minister as well, to give an assurance that 13.1 million, given that money for waiting lists was reprofiled, to give an assurance that this money will be protected.
Yeah.
I just raise the usual point again, as we just regularly make, having 4 reps, you just get bamboozled by information. If you've got 4 people answering all the questions that we're doing, I don't know if it's always the best way to do it, because I think they talk over the top of each other or from different perspectives, and it just becomes a lot of information, and I don't know if we're any further forward at the end of it, given that we've more questions in the end than we nearly had at the start.
Yeah, to be honest with you, I'm actually thinking, and I don't know if this is something that we can do, because I'm just conscious the point Nuala made and they made about individual cases, whether an informal meeting maybe with the families and the department there, where you can kind of tease out some of these issues so that they don't have that excuse. I don't know if that's something that we can investigate doing.
We have the parents scheduled for the 30th of
June. So we have the parents scheduled for the 30th of June. I mean, I think we'll know the answer about Redwood by then for sure. So I suppose we can assess it after that. Okay. Right, moving on then. Item number 9, written briefing from the Department of Violence and Aggression towards staff. So there's a written briefing, page 142. I mean, as per usual, it's discussing the levels. I mean, we've obviously mentioned the recent added issue of racist violence against our staff. So I don't know if anybody has any additional comments. I mean, we're getting written briefings. It's just disgusting that people who are out working in the healthcare sector are subject to this level of violence and aggression for doing a job that they're doing.
Chair.
Yes, Dan.
No, it's just, again, given that this is an issue that isn't going away, and that it is an issue that I mean, I think most right-thinking people cannot imagine why this happens towards our staff. We should be asking the department, are there any new strategies that they are developing to actually say, because what they're doing doesn't seem to be working. And sometimes when I speak to staff, particularly about this matter, they say, sometimes I don't even report it. I go home. I know one person who goes home and is almost distressed, cries and says, I'm not going back again, because of the level of aggression towards them in the ward. This is not an A&E, in the ward. And so I can't report it because nothing is ever done about it. I'm just told it's the way it is. It's pretty poor. It's pretty poor, the response in general. Except it's this. I'm talking about ongoing aggression as opposed to the high profile incidents. I mean, I did see the headline today where it said about a nurse running in followed by masked men, and that's appalling. It's appalling. But I'm talking about this ongoing level of aggression that our nurses face day in and day out in the ward, and I just don't think that what's being done is enough. It's certainly not effective.
I've done any on Colin.
Thank you. Yeah, the incident you referred to is disgusting racism, and I'm sure everybody in this committee would be absolutely in full condemnation of those masked men chasing a nurse into a hospital shift. Appalling. And I do hope that nurse is okay and remains in the job. I do I am worried that we are going to lose healthcare workers because of ongoing attacks and living in fear of themselves and their families. Sadly, that's where we are. This isn't recorded, within these numbers. We have met with the Northern Trust with the cameras, and they were very clear that in A&E, where they'd rolled out the cameras, that they had seen violent incidents drop. I think it'd be interesting to ask them if they have more figures now that we can make a comparison. I know they've rolled it out in other areas or rolled it out more widely in A&E since. But you're right, Diane, it is vastly underreported. I know staff that have been assaulted and have never reported it. The verbal abuse, I don't know anybody that's ever reported verbal abuse, so I'm stunned that there's numbers there, yet it happens constantly, all the time, every day. What I would like to ask is, while we have these figures of people being attacked, do we have figures of people who have been brought through the courts? Can the Trust tell us how many people they have caught on camera or other evidence and brought through the courts on this? And I would encourage all staff to report any incidents so that we have the clearest possible number of incidents, and so that we are aware of the whole picture. This is underreported, we know it is, and there should be zero tolerance for any violence against healthcare staff. Thank you.
Paul?
Chair, I just wondered if we can ask them if they might be able to include a separate examples of when it's racism that actually is the cause for the violence, because there also needs to be an acceptance and understanding of what we stand on our feet and stay in the room down the hallway from here has a direct impact on staff on the ground. And some of what we hear being thrown about in the chamber, I have no doubt leads to groups of people walking about the place and behaving in certain manners. And I think we have to be really careful about the language that we use in this building and how it impacts people out there. But if we've got healthcare staff, which I think is one of the biggest employers of people of different ethnic backgrounds that are resident here, it would be able to good to see if we can capture just how many of those incidents of attacks are linked to racism.
I think that would be good. On Danny's point, we've asked for that information about prosecutions and whatnot, so we're still awaiting that. I mean, I think, Dan, in terms of the new strategy, I know from correspondence from the RCM that they would probably have asked about the current strategy being implemented rather than a new strategy. So I do think that day we met with the Northern Trust, there was hope that the rollout of the cameras, there's no doubt that was having a very positive impact in the areas where it was worn, and that's not everywhere. I think I would be encouraging all our healthcare staff to be reporting ongoing incidents. I know I can share their frustration, but I do think it is helpful that we have it recorded so that it does help to keep the pressure on. Yes, Al.
Yep. The attacks of the last few days on people of ethnic minorities, the majority of whom are working in our health service, it's only the latest. This has been going on for the last number of years, and the morons that are doing it do not realise that these are people that we need and that we should be cherishing rather than punishing them. It's absolutely awful. But going back, I remember here a couple of months ago we were talking in here about, we were getting reports about the violence in the wards, and I think it was around the time we were talking about the body cams and stuff. And I asked a question, and I was quite surprised to hear that there was actually aggression on the ward. I couldn't get my head around that. Why would people be aggressive in the ward? Now I know people maybe there's grumpy people, and if they're in hospital and they're suddenly like a caged animal, they'll be aggressive vocally aggressive. But the problem, I think, is what do you do? What's the retribution you take against somebody who has just said something really nasty, maybe not even around racism, just something nasty to the nurse or about their treatment or whatever? What do? Do you say to them, "Well, right, get out, we're sending you home, you're no longer a patient in here," or "We're not going to serve you any food for the next 3 days"? How do you address it? It really is a really tricky one, and we keep talking about educating people, but there's some people that, as we've seen the last few days, some people you just can't educate. But I don't know how we deal with it in the hospital, in the ward setting. It's terrible.
Agree with all of that. Okay, members, moving on then to item number 10. So, written briefing from the department on the review of Emergency General Surgery at the South West Acute Hospital. So, there's a written briefing at page 3 of the table papers. So, obviously, I mean, we're discussing this, but yesterday we had the RQIA report. We're discussing that next week. So, I mean, I'm pretty sure members will have some commentary even in advance of next week. I think that the report obviously acknowledges some improvements in the emergency pathway under difficult circumstances, but it also makes clear that what was intended to be a temporary solution is now 4 years in place. So that's not temporary, and in that 4 years, patients in Fermanagh, Southwest, it's saying, according to RQA, are continuing to face long journeys, uncertainty, additional pressures on families. And I mean, I think the committee will certainly want to interrogate and see a long-term sustainable future for services in the Southwest. I don't think it's acceptable that patients and staff are facing into this uncertainty 4 years on. The department, in my view, needs to ensure resources and infrastructure are put in place to deliver safe, effective and equitable access to emergency surgical services in the West. That's just my view.
Chair.
Dan?
Yes, I agree with everything you've said. I've just been flicking through the RQIA report, and some of it is quite sobering reading in terms of, you know, the Northern Ireland Ambulance Service, for example, operated this transfer using overtime, and then because they didn't have any recurrent funding for it, couldn't do that anymore. As a consequence, they're now operating with private ambulances and the Northern Ireland Ambulance Service quota for the area as well. And, you know, it's this lack of long-term planning. We're just bumping along one bit after the other. And next week we're going to have our QIA, is that right?
Just we're basically have scheduled next week to discuss the report, Dan, even though we're discussing it now.
Right. So, well, I mean, one of the things that could we ask that the department then and the Western Trust send us for next week what their plans are for this new vision plan that the minister had outlined for the SWAH. I haven't seen anything much about it at all in the last number of months. It seems to have gone into hiding. So along with the report, what's the future look like for the SWAH? What's happening about the SWAH? What are the plans? What does the Western Trust, what are they developing? So we can have some sense of where it's going.
Yeah, Chair, it's about just being able to find, I mean, there's a massive disconnect between what the Trust says, what the department wants, what the community's telling us and what the reality is. And I just don't think that we can allow this to drift any longer. I mean, I think we're getting very, very close to the stage where the current minister is going to say, I'm not going to have time to do anything this in my tenure, and it's going to be over to the next health minister, and that could be a year away before it even gets onto somebody's desk and we move from there. And it just seems desperately unfair on the people down in Fermanagh to be left in a manner like this. And I just think that we should be doing everything that we can to try and bring those various strands together and say what's happening, because we can't have one, like the Trust telling us everything's rosy in the garden and it's saving lives, and then the reality on the ground is that people are saying that's not what's happening.
And RQA, I mean, they're saying the whole pathway needs to be looked at. So absolutely. So we'll have a longer time to digest that for next week.
Okay. Chair, is there any way that we can get an answer on the vision plan that the minister talked about? Because I think that in the absence of actually knowing what they're planning, we're going to talk about the same things over and over again. We talked about all of these things when RQIA were with us before. And that's not good enough, because we're just going over old ground. We now have a formal report from RQA. Fine, that's fine, and it's helpful. But also, we can't talk about all the problems and all the things that RQA have said about the improvement plan should be, all of those things. And I'm happy to discuss those. But I also want to know, and I think the people in Fermanagh need to know, what is the future? What's the future hold for their services? And where's the visioning plan, and where are the Western Trust with it? What are the department doing to input into that visioning plan? It's really, really important for those folk. And as Colin says, we can't just waste around talking about this in endless circles.
Yeah, well, I mean, unfortunately, we're the committee, a lot of this is decisions for the Western Trust and the department, and I mean, I get the sense that there isn't a meeting of minds on who's responsible for some of these things. I mean, as we've seen on our last visit to the SWAH, where you have the Trust saying this is the Minister's responsibility, and the Minister saying it's the Trust's responsibility, even in particular to the vision plan. I mean, what I would hate to see, and I mean, I'm not saying it is the case, but that things are put on hold because of an election coming up.
Well, just I think we need to be careful too with our use of words around the SWAH when we talk about its future. I think what we're really talking about is the future of emergency surgery in it. And I think we've heard the Minister say we saw the day we were there to visit. It's a vibrant hospital. Yeah. It's you want one at the end of your street. It's such a modern building and everything else. And there's lots and lots of stuff going on in there, serving the public down there. So we need to be, I think sometimes when you talk about the future of something, you're putting a question mark over the future of the whole thing. But just one wee thing, just a bit pedantic. Colin drew my attention to the fact that the report that we got on the SWAH was security marked with our initials on it. Now normally that would only be done like somebody in the policing board that was something was MI5 secret or embargoed or somehow. But there was no indication that there was anything to stop us sharing that report with other people. But I just wonder what was the unique use of initials on that report.
Usually observant I am. I ain't noticed that. But your point of clarification is right, and we also always need to remember the South West Acute Hospital is an absolutely excellent facility. It's got a vibrant future ahead of it. What we're discussing is one particular aspect, and I mean that is a very important clarification, but a very important one for the people who from Fermanagh who are very passionate about having healthcare provision locally. So we'll come back to this next week. So SOAS have asked that the departments that we can forward on to him. There's no reason why we can't do that. No, okay. So I suggest that we send that on to the SOAS group. Okay, members, item number 11, written briefing from the department.
Why was it watermarked with unique and idents on it?
Which document was this, sorry?
The table papers.
The table papers
has their initials and a number on it, but just that's normally only done with embargoed things. Was it embargoed, or did the department ask for it to be embargoed, or
is this the departments of the RQIA? Because I didn't notice this.
The table papers.
Oh, sorry, I see it there. Actually.
Are marked?
There's mine.
They are there.
Yeah. Oh, marked with your.
I didn't pick up on that.
Which is normally only done if it's embargoed.
Absolutely.
But it wasn't embargoed.
It wasn't embargoed. There's no issue with it. I think it's just maybe a case, maybe a wrong button's been hit on our side that's made it look that way. But it's certainly it's not something that came embargoed, and it doesn't make it makes it, there's no confidential marking on the original document. So it is. So it could just be an issue in our ECP system that it's went out that way, but I will look into that, but it's certainly not.
It's not. Okay,
it's not. Perfect. So it's not.
Sorry, I did notice that. I wasn't even sure what you were talking about there.
You wouldn't share it normally.
It doesn't come up in the ours, so it doesn't. There's nothing in.
The original one that was sent on.
Yes, but even when we look at the table pack here, there's nothing in it, so there's not. So
anyway, people out there will be wondering what we're talking about. We'll sort that out. Don't worry, everybody out there. Item number 11, written briefing from the department on the new children's hospital update. So that's at page 160 of the main pack. Any comments? No.
Yes, sorry,
Okay.
Chair.
Should have went quicker, Chair.
Can I just say, if that's an update, like, what?
A photograph.
It is appalling. It is appalling.
Yeah.
I mean, it's just a statement of facts and a photograph of where. Like, it's really exciting to have a new children's hospital. I'm really pleased about that. And if you're like me and you've spent months and months of your life in the children's hospital, you know, you'll understand that really well. But you know what? That's not really an update for this committee, really.
In fairness, you know, we're getting updates every 3 months. Yeah. So I mean, they do detail the progress of what's been built and some of the things. So it's a wee bit more than a photograph, Dan. But I take on board. Maybe we should. Maybe we should. I mean, I don't know if there's anything else over and above what we're getting that we want with an update. Maybe that's something that we should consider. Maybe we should get updates slightly longer than every 3 months. I don't know. Or just keep it. I think we'll keep it as it is, and then we'll be surprised whenever the whole thing we go up someday and it's built.
Okay. 4 cranes next time. Wouldn't that be fabulous? More than the 3.
Compare the pictures. Okay.
Sorry, Chair, just to the important bit there is the project spend remains on budget compared to other projects.
That could be the case, Danny, right up until
wait till you get the last one.
Wait till the ribbon's been cut. Okay, but it's a fair point. We shouldn't take it jokingly. It is important. Okay, written briefing from the department on the mental health strategy. So there's written briefing at page 187. Any commentary on that?
Just the usual, Chair. Like, it's a strategy that doesn't have money, so how can it do what it set out to do? But it's doing something, which grand, but not enough.
Yeah, I mean, just the proposals for transition between CAMHS and adult mental health service remains rated red. So, I mean, I think that's a concern, just given that we've heard today in terms of transition. So that's an issue right across all services. So it is. Okay, correspondence. Correspondence, I can refer everybody to the main pack 215. There's a correspondence index at 217. So just a couple of things. The department responded to our letter to them regarding the Atherton report. That's at page 264. I mean, it's a kind of disappointing non-response, but I mean, I'm not sure we're going to be shocked by that. So I don't know if anybody has any commentary on that. Okay, also there's correspondence from NICMA, NICMA at tab 1417, and that's a request to brief the committee. I don't know if anybody has any commentary on that. Informal meeting? No? I don't know if people have any views on it. None? Can we do it informally?
Just to say, Chair, we have committee clinic in September, which is now full.
Okay.
So it is. So it would be a case if we were doing another one, we'd be looking
near Christmas.
If we're talking legislation being heavy, you're probably talking February time rather than.
Right.
But
okay.
Certainly, if members wish, we can add them onto the list.
If it's just going to add an extra one, I think we could probably add them on the list and stay a bit longer. I'd be happy with that. Okay, so members, then there's correspondence from the Gateway organisation regarding a request to brief the committee. So I've just kind of said one. I don't know. Do members have any? I mean, I'm happy enough to meet and engage with all of these groups that want to meet us, but
we will have a further conversation next week about our forward programme from sort of September onwards.
Okay.
So we can list all of these and then look at a way of managing that, Chair, if that works.
That's perfect then. So we also received correspondence from the Newington Day Centre at tab 14 of the table of papers regarding support for Fontaine. So I mean, I think we should forward that on to the Minister just. People are happy
Chair,
enough.
can we make that a general inquiry as well? I also got that because obviously from a North Belfast point of view, I know them as well. But it seems to me that that's an issue that is probably common to a lot of day centres across Northern Ireland.
We should ask for an update on what the situation is right across
Yeah.
the board. Okay, fair enough. Okay, members, also correspondence from Children NI, page 29 of table papers regarding an invite to all-party group on children and young people on 16th of June at 1 p.m. So we're all aware of that. Okay, is everybody content then with the suggested actions in the index at 217? Okay, thank you.
Sorry. Oh, sorry.
You want to come on down?
No, it's the letter at page 400 of correspondence.
Yep.
I mean, it is very, very concerning, the issues within the letter. I know that we will have the gender clinic at the end of June, but when a parent includes the issues that are included within this letter and the advice to children that organisations that are receiving public money are being given, it is quite disturbing to hear that, particularly about this one is about Childline in particular. I do intend to take some of these issues up, but I think that it is actually really, really disturbing to read that letter and to read some of the snapshots of material that have been sent to us as well.
Yeah, well, I mean, we've agreed to forward it to the department, so we'll get their views, so we can potentially comment on it later.
This is a department that is an organisation that receives public money, and it is very concerning that if an organisation is giving out advice on how to buy puberty blockers, and I don't know how old this advice is, so it need to be clear and so on about it, but like that is very concerning.
Okay, members, forward work programme, refer members to the draft forward work programme, page 418. So there's a briefing from Belfast Health and Social Care Trust on the Muckamore Abbey Hospital Inquiry Report, and we've provisionally added that to the forward work programme for the 3rd of September 2026. So committee staff have added timings to the forward work programme for forthcoming legislation as far as possible. Members should note these timeframes remain subject to the receipt of the legislation, so we need to get it first of all. So we have a further discussion next week on the forward work programme. That's a hard word to say. With regard to legislation, so we'll discuss this more next week. We might everybody should note and hopefully put in their diary. We have an informal meeting with Mark Taylor on the 16th of June 2026. That's going to be very important. We've decided rightly to have a focus on the waiting list, particularly red flag waiting list. So updates from Mark are very useful with regard to the business that we're carrying out. Also, there's a committee visit to the men's shed in Ballymoney on the 25th of June 2026. So I hope to see everybody in North Antrim and Ballymoney then. So everybody's content with the forward work programme in our business?
Yes, Chair.
Yep. Go ahead.
Chair, just to let members know, I attended the Infected Blood Compensation Authority event this morning in Belfast. It was a roundtable event attended by people from the community and people from the Compensation Authority themselves, the national one. And it was just about the progress of the compensation scheme, and I know the committee here has taken an interest in this as an issue. We've been briefed by Nigel Hampton. Wondering if we could ask them to come up and give us a brief just to explain how it's progressed and how people here are being affected. It's due to be handed over from BSO to the Compensation Authority in February, and there are concerns just about how that's going to be managed.
So we can add that to our discussion next week then, can we? Okay, next meeting. Date, time, place of next meeting is, you'll be surprised to know, here next Thursday at 2 p.m. Meeting adjourned.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29, Sound. Committee Room 29, Sound.